Uh, we have the atria, we have the left atrium, and we have the right atrium, which are the atrial cavities. And we have the two ventricles, we have the left ventricle, and we have the right ventricles. The main function of the atria is to pump blood from the atria, from the either the left atria or the right atria to the left ventricle and to the left ventricle. And the main function of the ventricle is to pump blood to the systemic circulation, either to pump blood to the aorta, which will allow for blood to go from the ventricle to the systemic circulation via the aortic valve, which is a valve that opens and closes depending on the cardiac cycle. So it will allow the blood to go from the ventricle to the systemic circulation. And we have the right ventricle, which will allow the blood to pump into the pulmonary arteries. The blood, which is rich in carbon dioxide, CO2, will go to the pulmonary arteries and there to reach the lungs. And when it goes to the lungs, we'll have oxygen, we'll have CO2 that will go out of the body and oxygen that will come to the blood circulation, and the blood supply will then go to the left atrium via the pulmonary veins. So we'll have blood rich in oxygen that will reach the left circulation in order for the cycle to start and the blood to go back to the aorta and to the systemic circulation. But in order for all this mechanism to happen, we need to have an electrical activity in the heart in order to allow for the cavities to contract permanently and to pump blood permanently. So we need electrical structures that can produce electrical activity, and we need fibers to spread this electrical activity to different parts of the heart. So the main structure that will produce this electrical activity is the SA node, which we call also the sinoatrial node. So the sinoatrial node, you can see here on the second picture, the sinoatrial node will produce electrical activity. The electrical activity will then spread from the sinus node through the right atria and to the left atria. So this will allow the atria to contract simultaneously, because the electrical activity will go to both atria at the same time. So they will contract simultaneously and they will both pump blood simultaneously to the left ventricle and to the right ventricle. After the sinoatrial node, the electrical activity will reach another structure which we call the atrioventricular node. So you can see it here, the AV node. It's located in between the atria and the ventricle. And this AV node is another heart pacemaker, or we can call it generator. This AV node will produce electrical activity as well when the SA node stops functioning. So it's like an SOS mechanism in order to prevent sudden death or sudden loss of electrical activity. The AV node can start producing activity at a lesser rate, so it's slower than the SA node, but it's like an SOS mechanism in order to keep the heart functioning. So the electrical activity, when it reaches the AV node, it will then go to the His bundle, which is another conducting system. And after the His bundle, we have the bundle branches. So we have the left bundle branch and we have the right bundle branch that will allow the electrical activity to go to the left ventricle and to the right ventricle simultaneously. So we'll have right ventricle contraction and left ventricle contraction at the same time. And then we have finally the Purkinje fibers, which are the small fibers located inside the myocardial cells. So we have a very complex electrical activity system that will allow the electrical heart conduction. You can see another structure which we call the Bachmann bundle. This Bachmann bundle allows for the very rapid transmission of activity, electrical activity from the SA node to the left atria, because you can see the left atria is located a bit further as compared to the right atrium. So the right atrium will receive electric activity a bit faster, but this Bachmann bundle is very fast and will allow for transmission of activity to the left atria at the same time of the right atria. So we'll have simultaneous contraction of both structures. You can see that the SA node produce activity allows the heart to have a normal heart rate between 60 to 100 beats per minute. But for example, when the SA node stops functioning, the AV nodes will takes the initiative and will become the main pacemaker cell of the heart and will produce activity of between 40 to 60 beats per minute. So it's a bit slower, the AV node. Can you hear me? Someone is saying that there's no voice. Okay, great. So now we'll go more into the details. We said that we have the His bundle of His and we have the bundle branches, which are located in the interventricular septum. But the right bundle branch is a unique structure. But the left bundle branch will divide into two structures. We'll have the left anterior division and we'll have the left posterior division. So the left bundle is more complex as compared to the right bundle, which is a single structure, as compared to the left bundle, which is a double structure. So in summary, this is the electrical map of the heart, electrical conduction. It's like electrical fibers that conduct electricity, and we have a generator, which is the sinoatrial node, will send electrical fibers to the AV node, which will allow for atrial contraction and atrial pumping of blood to the ventricle. Then we have the bundle of His and the bundle branches, and finally the Purkinje fibers, which will allow the electrical activity to reach the ventricles and to allow for ventricular contraction in order to pump the blood to the systemic circulation and to the lungs via the aorta and the pulmonary arteries. So the sinoatrial node, now we'll talk about each of these structures alone. The sinoatrial node is banana-shaped structures. It has different sizes depending on individuals and depending on age. But usually it has a size of 10 to 30 millimeters, so a diameter of 10 to 30 millimeters, and it's wide 5 to 7 millimeter wide, and it's 1 to 2 millimeter deep. So it's a very thin structure that is generating all this electrical activity. Okay. So in order for this SA node to produce activity, like any other organ in the body, it should receive blood supply as well. So if we don't have blood reaching this structure, there is no electrical activity. So the blood supply comes to this structure via an artery which we call the SA node artery. The SA node artery will originate from the right coronary artery. So the right coronary artery is a major artery supplying the myocardial cells. So we have a branch from this artery which will give supply to the SA node. You can see this is an angiographic view of the right coronary artery. You can see that it has different branches. The branches at the end are the IVP branch and the retroventricular branch. But we have the sinus node artery. You can see it comes directly from the proximal aspect of this artery. So you can see it clearly here, the sinus node artery, which will go to supply blood, to give blood supply to the SA node. So, but not all patients receive blood supply from this artery. Just 60% of individuals will receive blood supply from the right coronary artery. The rest will receive blood supply, so 40% will receive blood supply from the axial complex artery, which is an artery originating from the left system of the arteries. And just 1% will have anomalous origin of the blood supply, which can come directly from the aorta or from the coronary sinus, which is rich in CO2, or from the distal right coronary artery. So we said it comes from the proximal right coronary artery, but 1% of individuals will have anomalous origin of this circulation. In order for this SA node to produce electricity, we said it needs blood, but it also needs to have innervation. So we need nerves also to monitor its function. So the main two neurologic supply to the SA node comes from the midbrain area. So we have parasympathetic fibers and we have sympathetic fibers. The parasympathetic fibers you can see here in red in the figure. These fibers usually are called the vagus nerve, which is a cranial nerve number 10, will give innervation directly to the SA node. This will allow for the heart to drop the heart rate and to decrease the heart rate, while the sympathetic fibers, which are colored in green here, are more complex structures. They originate in the midbrain area in the brain. Then they will go to the spinal cord, and they will have multiple synapses of neurons, and the end part will reach the SA node. This will induce the heart to increase the heart rate. The neurotransmitter or neuromediator here is norepinephrine, while in the sympathetic is acetylcholine. So we have neuromediators that monitor the function of this SA node and the electrical activity generation from the nodes. So we have blood supply, we have innervation in order to produce electrical activity. Here is a more detailed picture. So it's the same as the vagus nerve, which is here in purple. It's a parasympathetic nerve. And we have the sympathetic nerves, which is in green. We said it originates in the midbrain, then it goes to the spinal cord, and then it have another connections to reach the SA node. Okay. So the impulse from the SA node we said that will go to the AV node via the intraatrial muscle bundles. So we have muscle bundles here that will transmit activity from SA to AV, and we said before that we have the Bachmann bundle, which will transmit activity from the SA node directly to the left atrium. So the left atrium here is located on the right side of the image. So here is the left atrium, and here is the right atrium. We have the Bachmann bundle, which allow very rapid electrical activity transmission. So now we move to the AV node. The AV node is an electrical connection between the atria and the ventricle. So we said it's located in between the atria and the ventricle, and it plays a crucial role in coordinating the heartbeat. And it can sometimes be the pacemaker cell. So when the SA node stops functioning, it can generate its own activity. But the main function of this AV, atrioventricular node, is to transmit the normal electrical impulse from the atria to the ventricle. And you can see its size is a lot smaller as compared to the AV node. So it's 1 × 3 × 5 millimeters. So it's smaller in size. And it's very important here to know where it's located exactly. So we said it's between the atria and the ventricle, but if we go deeper, it's located in the center of the Koch triangle. It's an anatomic structure, the Koch triangle. I will show you another picture. So here is the Koch triangle. It's an area between the atria and the ventricle. And this triangle, you can see it has 3 borders like any triangle. So the first border is the septal leaflet of the tricuspid valve. So you can locate it here. It's the septal leaflet of the tricuspid valve. And number 2 is near the intraatrial septum. So between the atria, it's called the tendon of Tadaro. And the number 3 is near the coronary sinus. So it's not a real structure, but we have a lot of landmarks here that helps us locate the AV node. And when we find all these 3 structures, normally the AV node should be in the middle of this triangle. Here is a real view of the heart. So this is a human heart, a picture of a human heart. You can see here we have the Koch triangle. It's delimited by the septal leaflet of the tricuspid valve, which is here. And we have the coronary sinus, which is here down the triangle. And we have the tendon of Tadaro, which is on top, and the AV node should be in the middle of this triangle. This is very important because when we have a lot of procedures in order to, when the AV node stops functioning or when we have arrhythmias, we need to work on the AV node in order to modulate this electrical activity. So we need to know how to locate it. So we can, now we have a lot of systems like 3D mapping, but before we just had fluoroscopy. So fluoroscopy can help us also locate this triangle and locate the AV node, which is at the center. So like the SA node, we said that the AV node, the SA node needs blood and innervation in order to function. Same for the AV node. So, but here, most of the time, 80 to 90% of cases, the innervation comes from the right coronary artery. In the AV-SA node in blood supply, we said it's just 60%. Here, it's 80 to 90%. And the remaining 10% of cases, the blood supply will originate from the left circumflex artery. Okay. So you can see here is a fluoroscopic view of angiographic view of the right coronary artery, the same image that we saw before. But here the AV nodal artery comes from the distal or right coronary artery, unlike the sinus node artery, which comes from the proximal right coronary artery. So here it's a bit distal to the vessel. The AV node embryologically will develop. We have a lot of mediators for this development. We have something called the bone morphogenetic proteins, which are signaling molecules with a lot of function. They help in cardiac differentiation and morphogenesis. So this is in embryogenesis and the fetus life. So and this molecule also has a lot of receptors like the LK3 receptor, also known as activin receptor like kinase 3, which is located in the AV nodal area, which allow for the AV node to differentiate and to develop. And anomalies in these molecule and signaling pathways will cause a lot of cardiovascular conditions like AV conduction disease, we'll have AV block, and we have a lot of other rare anomalies that we will discuss later on. So the AV node will introduce a delay of about 0.09 seconds in conducting the impulse. And this delay is very crucial to ensure that the atria contract and eject blood in the ventricle before the ventricle contracts. So the AV node has a role to conduct electrical activity, but also has a role to slow down a bit the electrical activity. So the delay serves as a protective mechanism because preventing excessive rapid ventricular response to atrial arrhythmias, because sometimes the atrial arrhythmias like atrial fibrillation or other atrial supraventricular tachycardias the atrial activity will be very high. If the AV node conducts all the activity to the ventricle, will have ventricular tachycardia and ventricular fibrillation. So the AV node will slow down the electrical activity that's originating in the atria in order to prevent rapid ventricular responses in the ventricles. So we have two pathways in the AV node. We have the slow pathway and we have the fast pathway. Usually, all the electrical activity should go from the atria to the ventricle using the fast pathway. So the fast pathway is the main conduction. When activity go to the slow pathway, we'll have generation of arrhythmias. But here it's not our topic to talk about arrhythmias now. So we're just talking about anatomy. We should know that we have slow pathways and fast pathway inside the AV nodes. So here is another illustration that shows that 90% of blood supply of the AV node comes from the right coronary artery and just 10% from the left circumflex artery. We already said that. For the innervation, same for the exactly the same for the SA node. We have the same innervation. We have the in red the parasympathetic vagus nerve fiber that will reach the AV node here. It's mediated by acetylcholine, and we have the green, which is the sympathetic fiber, which will originate in the midbrain and then of the brain, and then go to the spinal cord, and then reach the AV node. And here it's mediated by norepinephrine or noradrenaline, which will cause increasing in the heart rate activity. I already say that. So here is another illustration talking about the same topic. You can see the vagus nerve, which is the cranial nerve number 10, which is the parasympathetic fiber. Okay, so now we talked about the SA node and the AV node. Now it's time to talk about the bundle of His, which is located down to the AV node. So it's positioned in the intra-atrial septum near the AV node. So it's very close to the AV node. The structure of this His bundle contains bundle branches and other specialized fibers. So it closely connects connect to the AV node, which will coordinate ventricular function and transmit electrical activity that was generated in the SA node and AV node to the ventricles in order to allow for ventricular contraction. Okay, so the His bundle, as we said it many times, it serves as a crucial bridge between atria and ventricles. It facilitates the rapid transmission of electrical impulses, allowing for the coordinated contraction of the heart chambers. Now, when we talk about blood supply, so you can see here the right coronary artery, it supplies blood to the SA and to the AV node. And it may sometimes supply also blood to the His bundle. So we can have blood supply to the His bundle, but also here for the His bundle, we have another artery. We have the left anterior descending artery, which is a branch of the left main artery. It can give blood supply to the left side of the heart and to the interventricular septum. And we said that the His bundle is located there, so it will have blood supply from the LAD, but the LAD doesn't supply the His bundle directly. It supplies surrounding tissues with oxygen and blood. So the His bundle will have his blood supply from this area, but it's not a direct supply from the artery. So we don't have a branch coming from the left anterior descending artery directly to the His bundle. It's just it supplies the area, and the His bundle is able to extract blood and oxygen from this area. So when we have insufficient or poor blood supply, what will happen? So we'll have conduction anomalies, we'll have heart block, which will be, and we'll discuss it later today, and we'll have arrhythmias. So this will need immediate intervention to restore blood flow and to restore the electrical activity generation from these structures. Same as other SA and AV nodes, the His bundle is also innervated by the sympathetic nervous system and the parasympathetic nervous system. And the main function of these nervous systems is to modulate the activity, to increase activity or reduce activity, increase heart rate and induced heart rate, increase contraction or reduce contraction. So we talk about chronotropy or inotropy, and we can inhibit or favor these functions in the heart via the nervous system. Now we move to the fourth structure that we'll discuss, which is the bundle branches. So the bundle branches, you can see in the figure, are colored in yellow. They are located next to the His bundle. We have two branches. We have the right branch and we have the left branch. They are located within the interventricular septum. This interventricular septum is the structure that separates the right ventricle from the left ventricle, and it's a thin wall. Normally, it's about 10 millimeters in diameter. So it separates both main chambers of the heart. The bundle branches, like the branches we already discussed, play important roles. They transmit electrical impulses from the AV node to the ventricle, which will allow for coordinate contraction. So we have electrical activity going to the right ventricle and to the left ventricle simultaneously. So both structures will contract at the same time. There should not be a lot of delay, but if we have a delay, we'll have a lot of other diseases that we'll discuss later as well, but they should contract at the same time. So when the bundle branch are divided, as you said, in two branches, the right bundle branch and the left bundle branch. So the right bundle branch will conduct impulses to the right ventricle, and the left bundle branch is divided in two structures. We said before, the anterior fascicle and the left posterior fascicle. So we have left anterior fascicle, left posterior fascicle, and these fascicle will conduct impulses to different regions of the left ventricles. Okay, so the right bundle is a unique structure, while the left bundle will divide in left anterior fascicle and left posterior fascicle. The right will go to the right ventricle in order to allow for ventricular contraction. The left will go to the left ventricle, which will allow left ventricular contraction. Same, nerve supply is the same. We have the autonomic nervous systems, the sympathetic and the parasympathetic, originating from the midbrain, vagus nerve, and we have the sympathetic fibers that will go to the spinal cord. So it's the same innervation for all these structures. Okay, so sometimes we have decreased blood supply to these structures, or we have another pathologies will have blockage for either the right bundle branch or the left bundle branch. So we'll call it the right bundle branch block or left bundle branch block. This will impair conduction to either the right bundle, to the right ventricle, or to the left ventricle. And it's very easy to diagnose it. The diagnosis is on the electrocardiogram. So we do an ECG. On the ECG, you have signs that will allow us to diagnose bundle branches. So when one of these branches is blocked, the electrical activity will, for example, if the left bundle branch is blocked, the electrical activity will go initially to the right ventricle, and from the right ventricle, it will go after to the left ventricle. So it's not simultaneous conduction here. So we'll have a delay. And this delay, we can see it on the ECG by widening of the QRS complex. I will show you an example. So here we have a blockage on the right bundle. Here is the right bundle. We can see the blue blockage. So on the ECG, you will have widening of the QRS complex. If you see the normal ECG, the QRS complex is narrow, so it's narrow. It's a narrow structure. But when you have a blockage in the right bundle branch, the QRS will become wider, because here it indicates that the electrical activity going to the left and right ventricle is not going at the same time like it should go normally. So we have a delay, and this delay, you can see it on the QRS complex by seeing a widening of the QRS complex. Same applies for when you have a blockage to the left bundle branch. So electrical activity will start going to the right ventricle, and then it will go from the right to the left. So we'll have also a delay in the propagation. And this delay also, we can see it here. We have a narrow QRS in normal condition, but when we have a bundle branch block, we'll have a widening of the QRS complex. You can see that V1, the complex is negative as compared to the right bundle, where the complex is mainly going up. So this is how we differentiate on the ECG from right bundle branch block and left bundle branch block by looking at V1 mainly. So in V1, it should be negative wave in case of left bundle branch block, and in right bundle branch block, it's a positive, predominantly positive wave. So the treatment when you have a bundle branch block, usually it depends on the underlying cause, but usually we don't do anything. It's just an incidental finding, and pacemaker may be required, but it's not very common to have a pacemaker for bundle branches block. We'll discuss it later on. Moving now to the Purkinje fibers, which are the last part of the electrical conduction in the heart. These fibers are located within the myocardium. So now they penetrate inside the muscle cells of the ventricles in the endocardium layer of the of these cells. So they reach the inner surface of the heart chambers, and they spread throughout the ventricles. So they are very effective in transmitting electrical signals in a fast way. So they serve a function as a final stage of cardiac conduction, and they are responsible for rapidly conducting electrical impulses from the bundle branches to the ventricle muscles. They will ensure synchronized contraction between the right ventricle and the left ventricle. So as well, they are influenced by autonomic nervous system. So we have, same as before, parasympathetic and sympathetic to modulate their activity. We'll repeat. It's the same, exactly. It's the same innervation. And the blood supply here is more complex. So we can have blood supply coming from the right coronary artery. We have blood supply coming from the left anterior descending artery and from the left circumflex artery. And we can have blood supply coming from collateral circulations. Collateral circulation usually are found in older individuals. So the blood supply to the Purkinje fibers is very comes from different directions. So we rarely have lack of blood supply reaching these fibers because of the different origins of blood supply. So it's a protective mechanism. Now, what can go wrong? So we discussed all the normal structure of the heart, but what can go wrong in this system? So we already discussed bundle branch blocks. So we can have right bundle branch block and left bundle branch block. So under normal conditions, the atrial impulse move down to the right and left bundle branch of the ventricles at equal pace. But so this will allow the ventricles to contract simultaneously, as we said before. But when we have a blockage in one of these branches, the electrical activity will now go to an alternative route in order to reach both ventricles. And this alternative pathway will cause one ventricle to contract slightly later than the other, which will lead to the development of conduction delay. And we said that we can see this on the ECG by looking at the QRS complex, which will become wider. So we already showed you this image. So its diagnosis of bundle branch block is mainly on the EKG. ECG electrocardiogram is a very simple tool. You can see widening of QRS, and in the right bundle, mainly in V1 lead, you can see that it's predominantly positive wave, while in the left bundle branch block, it's predominantly a negative wave. This is how we differentiate between the two pathologies. The treatment, often there is no treatment required because it's discovered incidentally. But when a patient comes with a new onset bundle branch block, so we check an old ECG, there is no bundle branch block, and comes with a new onset bundle branch block that wasn't present before with chest pain, we need to think of acute coronary syndrome, and its equivalent left bundle branch block with chest pain is equivalent to ST segment elevation myocardial infarction, so equivalent to STEMI, which is a life-threatening coronary syndrome. I will show you now an example. This is a 65-year-old patient. You can see this ECG. There is no bundle branch block here. It's a normal ECG. This is his baseline ECG. But the patient later on presented with chest pain with new onset left bundle branch block. You can see clearly that the QRS has become wider. This was a narrow QRS. Here is a wider QRS. So the waves are now wider. And you can see in D1, it's predominantly negative. So it's a left bundle branch block. This patient was transferred immediately to the catheterization lab, and a coronary angiography was done and showed a total occlusion of proximal LAD. So we have a left anterior descending artery that was occluded completely, and this is caused the bundle branch block, the left bundle branch block, because we said that this artery gives arterial supply to the bundle branches. So this artery was blocked, so there is no blood supply to the bundle branches, so there is a blockage at this area. We treated this case was treated by placing a coronary stent inside the occluded left anterior descending artery after balloon dilation, and the flow was restored, and the bundle branch has decreased. So now I will show you a small video by the British Heart Foundation about the second anomaly that can originate from the electrical conduction of the heart. Okay.
Your heart. It pumps blood around your entire body, coordinated by an incredible electrical system. Normal heartbeats begin when your SA node fires an electrical impulse. This makes your atria contract, forcing blood into your ventricles. When the impulse reaches your AV node, it pauses before moving through your ventricles. This makes your ventricles contract, forcing blood out of your heart and around your body. If you have complete heart block, your AV node doesn't pass these impulses to your ventricles. A backup system will take over and keep your ventricles contracting. They will contract at a much slower rate. This means your heart will beat too slowly, affecting the flow of oxygenated blood to your body and brain. Find out.
Okay, so we'll talk now a bit about AV block. We have another lecture about AV block, so we'll just go. We'll not go to in the details. So first degree heart block, we have three types of heart block. So it's a pathology of the AV node. So the AV node is pathological here. The first degree heart block is when the electrical impulse moves through the heart AV node slower than normal. So here the AV nodes is functioning, but it's slower than normal. So we will have a longer delay as compared to normal functioning AV nodes, so slower heart rate. It rarely causes symptoms and treatment is not required in most cases. So the main causes of first degree heart block is when the AV node becomes slower is medications. So we have digitalis, which is a medication used to drop heart rate, and in heart failure, which is digoxin. We have beta blocker, which are medications used for a lot of indications like acute coronary syndrome, heart failure, or to drop heart rate for various types of tachycardia. Calcium channel blockers as well will cause sometimes a delay in the AV nodal conduction. So we have first degree AV block, but here there is no need for any treatment or any intervention. We can just monitor the patient. Now moving to second degree heart block, which is a more dangerous condition, but it occurs when just some electrical signals from the heart upper chambers reach the lower chamber. So not all the signals that are originating in the SA node are able to reach the ventricles. So here we have sometimes drop of some electrical activities. So we call it second degree heart block. So unlike the first degree heart block, which is just slower transmission of electric activity, here we have drop of few signals going from the atria to the ventricles. And this can be symptomatic, so it can cause symptoms like chest pain, dizziness, syncope. The patient can present with syncope or a lot of other symptoms, so we need to do an ECG to diagnose it. Type 2 AV block is divided in two types. So type 2 contains two types. First type is Mobitz 1 type, and the second type is Mobitz 2 type. So Mobitz 1 type is usually mild, so it doesn't progress to advanced, it doesn't cause a lot of symptoms. Here it should be just monitored, unlike the Mobitz 2 type, which usually requires a pacemaker implantation in order to restore the normal electrical conduction. Again, we'll discuss these topics in a later presentation, so we'll not go into the details. Third degree heart block here is the heart block electrical signal can't pass from the heart upper chamber to the lower chamber. So we have complete blockage. So not just few signals won't pass, here we have a complete blockage. So without electrical impulse from the sinus nodes, the ventricles will contract and pump blood, but at a slower rate. So as we said, we have an emergency mechanism or an SOS mechanism by the ventricles that they will start pumping independently on the SA and the AV node, but the heart rate will be a lot slower. The patient will be bradycardic usually between 30 to 40 beats per minute, and the patient will be hypotensive because there will be decrease in blood flow going to the systemic circulation. The same, it can be caused by medications, like we said, digitalis or beta blockers. Most commonly, it can be caused by heart attack. So heart attack, we have an occluded blood vessel, so blood will not be able to reach the AV node, so we will have a complete blockage of this structure. Heart surgery can sometimes cause AV block because in heart surgery we'll have edema around the AV node, so the AV node will be blocked because of the edema of post-op. Sometimes it resolves spontaneously, sometimes it needs a pacemaker intervention. We have some bacterial infection like Borrelia, which is very common in the United States, which will cause Lyme disease. We don't have a lot of it in our countries here. So this third degree AV block usually requires a pacemaker implantation. So here we need to treat. We can't just observe the patient. We need to treat it. So as we said, we'll discuss AV block in our last session of the day. Now we move to the last pathology that we will discuss in the conduction system, which is the long QT syndrome, LQTS. So you can see in the first image, the QT segment, we measure it from the start of the QRS complex to the end of the T wave. Usually it's normal, as you can see it in the first image, but sometimes this segment becomes a bit wider. So we call it here a long QT interval. Usually it's above 450 milliseconds, above 500 milliseconds to start causing problems. So it will become wider in time. Okay, so what does it mean to have a long QT syndrome? So long QT syndrome results in an extended time for the lower chamber of the heart to contract and to relax. So the time will be longer, as we said, and it can be triggered. So if you have a long QT syndrome, this syndrome can be triggered by sudden noises, for example, physical activity and intense emotions. So we have triggers for it. Most of the cases are, we have a lot of cases that are congenital, but we have also acquired cases. We'll start by talking about the congenital types. We have the 17 syndromes, but the most common are the long QT syndrome 1, long QT syndrome 2, and LQTS type 3. And here the pathologies are related to the calcium and to the sodium channels. So the channels that allow for the movement of potassium and sodium throughout the cell membranes. So we'll have decreased function of the potassium channels in the LQTS1 and LQTS2, and we have increase in function of the sodium channels in LQTS3. And you can see that the most common one is long QT syndrome type 1, and this syndrome is usually triggered by exercise. So if a patient has it genetically and he do intense exercises, he can trigger this syndrome. While LQTS type 2 is usually caused by emotional stress, so relationship breakups or deaths in the family or death of a loved one, it can induce this syndrome. While LQTS type 3, which we said it's caused by increased function in the sodium channels, is usually due to other triggers, mainly due to sleep. It can be triggered during sleep or triggered by high auditory stimulus. So what are the symptoms of patients with long QT? We said there is delay in the ventricular conduction. So the symptoms can be most commonly syncope. So the patient will lose consciousness suddenly without any explanation. It can cause fluttering in the chest. The patient can feel the palpitation of tachycardia, can have abnormal heart rate or heart rhythm. So why we have these symptoms? When the QT segment becomes prolonged, as you can see on the second ECG here, and when the patient do the triggers, so we said emotional triggers or sleep or exercise, there is a risk of developing a life-threatening tachycardia, which we call it torsade de pointe, which is a type of polymorphic ventricular tachycardia. So patients that have a long QT syndrome are predisposed to have this type of tachycardia due to this widening of the QT segment. And when this tachycardia develops, there is a risk of syncope, seizures, and also if untreated, there is a risk of sudden death. When we see a patient with this type of tachycardia, we should immediately administer magnesium sulfate intravenously because this is the treatment of this condition, magnesium sulfate. If it doesn't resolve, we need to give a cardioversion, so we need to give a shock, electrical shock for the patient in order to revert sinus rhythm. And in very refractory cases, a pacemaker is needed in order to prevent this type of torsade de pointe or polymorphic ventricular tachycardia. We talked about the congenital, so the genetic diseases. Now we have other diseases like we have other acquired conditions. So these conditions are not present at birth. They are induced by various things like medications, most commonly medications. So we have medications that we use a lot. We have like the antibiotics, the levofloxacin, the ciprofloxacin, and other types of macrolides. So these antibiotics are very frequently prescribed for mainly for lung infections. So sometimes we prescribe this antibiotic. We don't look at the ECG. The patient has a long QT, and we give an antibiotic that can further prolong the QT segment. This will lead to arrhythmias sometimes and development of Torsades de Pointes or polymorphic VTAC, as we said. Other medications like antidepressant, antipsychotics like alloperidol, quetiapine, these medications are also frequently prescribed. And medications like antiarrhythmics. So we have a lot of medication you use to treat arrhythmias, but these medications are also pro-arrhythmics. So by treating an arrhythmia, they can induce another arrhythmia by inducing the prolongation of the QT segment. So we call them pro-arrhythmic medications like amiodarone, sotalol, or prokinamide. So amiodarone is very frequently used in the cardiac care units, in the hospitals, in the intensive care, for a lot of arrhythmias, but we should be very careful and look on the ECG in order to detect a prolongation of the QT segment. So for all patients on these medications, especially that patients that are hospitalized, we should do frequent ECGs like every 2-3 days in order to detect prolongation of the QT segment, especially if the patient is taking a combination of these medications. For example, he's taking an antipsychotic and an antibiotic at the same time. Here we should be do frequent ECGs like every 2 to 3 days in order to detect a prolongation of the QT segment in order to prevent the life-threatening arrhythmias that can be caused from it. Okay. So other causes of long QT segment. So we said we have congenital genetic these factors. We have the medication-induced. Acute coronary syndrome as well can cause it. So if a patient presents with myocardial infarction, so he can have a long QT on the ECG as well as a complication. Electrolyte disturbances, so a drop in potassium, a drop in magnesium, a drop in calcium can induce it as well. And if the last one is increased intracranial pressure. So when we have increased pressure in the brain due to stroke, ischemic stroke, or due to hemorrhagic stroke, this will induce an increase in intracranial pressure, as you can see in this case. So this patient has, you can see this hyperdense area on his brain CT scan. This is a bleeding of the parietal and occipital lobes in the brain. So we have a major bleed. You can see that we have a midline shift of the brain structure. You can see that the midline is shifted toward the left. So here is high intracranial pressure for sure. You can see on the ECG the patient developed widening of his QT segment. So the QT segment is now very wide with diffuse inversion of his T wave and ST segment. So this is typical for high intracranial pressure and pathologies involving the central nervous system. So it's very important, and it's very easy to diagnose long QT segments. So we need history. For example, patient said that he had an episode of syncope a few days ago. We do an ECG as a second step, and we can also do genetic testings in order to detect the congenital long QT syndromes, LQT1, LQT2, LQT3. As we said, these are genetic syndromes. And when we diagnose by ECG, then we need to check the risk for this patient to develop sudden cardiac death. So we have a lot of risk stratification tools, and in order to treat, so we need to avoid QT prolonging drugs like, as we said, antibiotics, antipsychotics, and antiarrhythmics. We need to avoid excessive exercise. We just need to do safe exercise like walking or running, but not an intense exercise. Beta blockers here are protective. So if the patient have a long QT, we can prescribe a low dose of beta blocker. It can protect him from developing ventricular arrhythmias. And for patients that develops syncope with this type of ventricular arrhythmia, we can place an ICD, which is an implantable cardiac defibrillator. So this device will give an electric shock for the patient when he develops this type of arrhythmia in order to prevent sudden cardiac death. And that was my presentation. Thank you for listening. And if you have any question, I can answer them now. Okay, so I have a question by Ahmed Khalil. Yes, the question is COVID-19 affect conduction system? Yes, we had a lot of cases of heart block, especially in cases of COVID-19 infections, mainly due to the development of myocarditis. We know that COVID-19 viral illness can cause myocarditis. Myocarditis can cause edema, especially around the interventricular septum and interatrial septum, which is around the AV node. So edema and fibrosis as a result of myocarditis can cause a conduction system anomalies. We have also as well, at the first stage of COVID-19, they use a lot of antibiotics which are inappropriate to use for viral illness, like fluoroquinolones or macrolides. They use a lot. So we saw a lot of cases of prolongation of this QT segment as a result of antibiotics. So it can cause, yes, AV block due to myocarditis, or it can cause also prolongation of long QT if you give an inappropriate treatment. Yes, same for COVID vaccine. If it has a complication to cause myocarditis, it's not very common, but a few patients develop myocarditis after COVID-19 vaccine. So mainly it's due to myocarditis and fibrosis around the AV node. It can cause AV block, but it's rare. It's not common. Any other questions? Someone, Ryan, is asking about if we can have the slides. I think, yes, you can have them. I will send them to the organizer at the end of the presentation. I think you can have them. We need to check, but I think yes. Okay, so now we will move to the next lecture, which is about introduction of an ECG, which will be presented by Dr. Amin, my colleague.
Good morning, everybody.
There's a question of a majority of patient takes aspirin 81 milligram tablet as prophylactic dose. It's recommended or not? Usually, we generally don't prescribe aspirin anymore as a prophylactic. especially in patients without risk factors, because it increases the risk of bleeding without giving a lot of benefit as an anti-ischemic prevention. We sometimes can prescribe it if the patient has a high risk. For example, if he has high risk to develop acute coronary syndrome, high cholesterol, diabetic patients, but usually it's not recommended to be given as a prophylaxis.
Good morning, everybody. Can you hear me? Can we start the second part? Okay. So you can hear my voice. And the slide is clear for you, correct? Okay, good. All right. So thank you, Dr. Anton, for the nice presentation. And we will continue based on that for the basic skills that are required to interpret the ECG. So first of all, is to grant a good conduction between electrodes or leads and the patient's skin is very necessary. Okay, so that's why we need to make sure that we clip and shave the skin and clean the skin with remove any dirt or anything that blocks the conduction, because we know that electrodes are transmitting or reading the electricity. They are voltmeters, okay? So if you are using a 3-lead machine for monitoring the right arm is on the second intercostal space, mid-clavicular line, the left has to be on the left opposite or counter side, and the last rib, okay, will have the left foot. If you are using 5 leads, you will distribute them on this distribution: right arm, right leg, left leg, and V1, it will be in its normal V1 in the 12-lead ECG when you are doing a 12-lead ECG, which is in the 4th intercostal space, right sternal border, okay? So this is the proper location. Now, if you place the leads wrong, your ECG is gonna read wrong. And we advise always people, if you look at ECG, one of the most important skill is to know whether you have a normal vector or abnormal vector. Because normally, okay, if you go from the right arm to left arm, okay, you will have lead 1, and from right arm to left foot, you will have lead 2. From left arm to left foot, you will have lead 3. So this is the normal distribution of the leads. Lead 1 is positive. And when we say positive, P1 is above the isoelectric line. I will just go a little bit in details in the introduction, okay? And lead 2 is also positive. Lead 3 is positive. AVF is positive, AVL is negative, and AVR is negative, okay? So when we talk about the normal direction of the leads, if you switch right to left or arm to leg, you will have a different look, okay? Now, if you switch left arm to right arm, okay, this is what's gonna happen, okay? You will get lead 1 inverted, okay? So if you are doing an ECG and lead 1 is inverted, and if you contrast it with lead 2, okay, lead 2 is positive, okay? So if lead 1 is negative, lead 2 is positive, definitely the one who have done the ECG had replaced left arm to right arm, okay? So there is a switch between the upper limb. Okay, and if you put left arm to left leg, and this is a counterpart, lead 3 become inverted. Now we agreed that lead 3 is up. This is the normal picture of lead 3. But if you counter this one, which is the normal direction, to this one, which is the switch between left arm and left leg, lead 3 looks inverted. So this is a wrong record. Okay, this is a wrong record. It's not acceptable. Okay, so that's why you need to repeat that ECG. Okay, you have to go and correct the lead placement, and then you can interpret the ECG. Okay, طيب. What do we look in the ECG? The ECG paper is made of boxes. Okay, it's made of boxes. The boxes are distributed into large box, which compose of 5 up, like vertical, we call it vertical, and horizontal. So when you talk about vertical, اللي هو العمودي بالعربي، يعني حتى ندخل شوية عربي في الموضوع حتى تكون الأمور شوي أوضح. Okay, العمودي أو the vertical is measuring volt. Okay, so each small box is a part of a millivolt. Okay, now if you look at the horizontal is a time, and majority of us when we look at ECG we use the horizontal اللي هو المحور الأفقي. each small box is made of 0.04 second. Okay, and this is the value that I use when I measure interval. For example, if I want to say PR interval is 3 boxes, 3 small boxes, then I will say 3 multiplied by 0.04, then this is 0.12. Okay, so when I refer to normal interval, because when there will be a talk about block, when I say there is prolongation in PR interval or a prolongation in the QT interval, it is the outcome of number of small boxes multiplied by 0.04. So the ECG paper is used as a voltmeter, okay, and the horizontal is time. Okay, now each 1 second composed of 5 large boxes. Okay, each 1 second is composed of 1 large second. That's why, or based on that, the 1 minute is 300 large boxes and the small are 1,500 boxes. So if you print 1 minute of ECG, you will get 300 large boxes and you will get 1,500. But for us, we take always a 6-second strip. This is the standard. The 6-second strip, it is a paper that has a 6-second long or length. It contains 30 large boxes or 150 small boxes. So when you take an ECG sample to fix it in your patient file, or if you want to use it for interpretation, it has to be a 6-second strip. Okay, this is for the interpretation. Okay, now when we look at the ECG, we give names for the wave component. So when I say a wave, the line that goes flat all the time, we call it isoelectric line. Means there is 0 electricity, there is recorded, okay, in this interval. Now, from the beginning of the wave, which is when the start of the isoelectric to go up and comes back, this is a wave. From here to here, this is the P wave. From here, you have the Q wave. This is the R, and here you have the S wave, okay? So any wave above the isoelectric line, we call it positive. Any wave below, we call it negative, okay? We call it negative. If it is normally positive, like in junctional, if it is normally positive, but it appears inverted, okay, negative, then this is an inverted, okay, wave. Now, the segment is the line between two waves. So from the end of the P wave to the beginning of the Q or the R, this is the PR segment, okay? And here is the ST segment, okay? Now, the interval is from the beginning of the wave to the beginning of the next wave. So that's why when you say PR interval, it takes the whole time of P wave and the time until the next wave happen. Okay, so that's why when I say a QT interval, it is from the beginning of the Q to the end of the T. PR interval from the beginning of the PR to the end of the PR segment, or the beginning of the new wave, which is either Q or R. Okay, now complex is when you say several waves. So the PQRST is the ECG complex. The first wave in our normal ECG or ECG is the P wave, and the P wave is representing atrial depolarization, or the contraction of the atria, or the systolic phase of the atria, انقباض اللي هو الاتريا. Okay, the normal P wave. Hello, what do you mean by normal P wave or sinus P wave? Number one, it is smooth and round. Second, usually it is short in its length or height, less than 2.5 small squares. Okay, positive in lead 1, lead 2 AVF and V2, V6, and maybe positive, negative, or biphasic on other leads. But when you are talking about a basic interpretation of ECG, we always take lead 2 as an example, and P wave will be positive to the QRS. Okay, so this is the sinus P wave. So small, positive, and I want to add another thing. It comes after a complete repolarization of ventricle. So you will see a complete developed T wave, then it is presented. Okay, then it is presented. So this is the sinus P wave. Okay, now let's give some examples. If I look at this P wave here, I have an isoelectric phase after T wave, which means I have a developed T wave. P wave here is positive to the QRS. It comes before the QRS and it is small, okay? Then this is a normal P wave. If you look at the second wave, what do you think? Is this normal or abnormal? Can somebody follow with me? Abnormal. طيب, let us apply the 3 criteria for sinus P wave. Is it positive to the QRS? Yes. Is it before the QRS? Yes. Is it after a complete repolarization T wave? Yes. Okay. This P wave is notched P wave. It is a P wave happen, okay, in some scenarios where you have 2 entries from AV node, from SA node to AV node. So by description, we are not talking normal or abnormal. We talk about sinus or non-sinus. This P wave is sinus, okay? But it is notched sinus P wave. إيش يعني notched؟ يعني there is a notch فيها عقدة زيادة. Okay, فيها عقدة زيادة. Now we might see this in a syndrome, we call it Wolff-White-Parkinson syndrome, okay? It's when we have an accessory or accessory pathway from SA node to the AV node. طيب, what about the third one? Is this sinus or non-sinus? Is it positive to the QRS? Yes. Is it before the QRS? Yes. Is it after a complete repolarization of a T wave? Yes. So this is a sinus P wave, but this P wave is peaked. okay? You might see this in patients who have hypertrophy, okay, of the atria. طيب, what about this one? Okay, the last one. The QRS is positive, the T wave is positive, but the P wave is inverted, okay? This inverted P wave, you see it in junctional rhythms, okay? You see it in junctional rhythms. So number 1 is sinus, number 2 is sinus, number 3 is sinus, but number 4 is junctional, okay? So this is how we distinguish P waves, okay? طيب, PR interval is the time of the depolarization of the right and left atria, okay? This is what does it represent, okay? Normal PR interval is between 0.12 to 0.20 seconds. The P wave to QRS, whether there is a Q or sometimes you don't see the Q, but because QRS is, we call it the R complex, okay? So that's why we call it PR interval. Normally is 0.12 to 0.20 second. Any sinus rhythm has a prolonged, okay, prolongation of PR interval longer than 0.20, which is 3 to 5 small squares, okay? So this is the interval in squares. We call it sinus rhythm with first degree AV block. Always when there is a change in the PR interval, it represents a kind of a block, okay? A kind of a block. The second wave is the QRS. The QRS is composed of the Q, R, and S as a complex, and it represents the spread of electric impulse through the ventricular depolarization. So P wave is atrial depolarization, the QRS is ventricular depolarization. Okay? The QRS measures, normal QRS measure 0.06 to 10. That's the reference. But it can go up to 0.12. So the average is 0.6 to 0.10, but it can go maximum to 0.12. Any QRS that is longer in duration than 0.12, we call it large or wide QRS. Any QRS between 0.06 to 0.12, we call it narrow QRS, narrow or normal. So it can go normal or wide, or narrow or wide. So your reference is this one, 0.12 second, which is equal to 3 small squares. If it extends to more than that, we call it wide QRSs, okay? Now, the ST segment is the proportion of the ECG between the QRS complex and the T wave. This is the ST segment in the yellow color, okay? It represents early part of repolarization of the right and left ventricle, okay? Now, the ST segment is always the representative of ischemia, okay? So always when I have a patient, if I have a patient who has ischemia, the ST segment, sorry, and I'm just jumping on the slides, okay? So the ST segment, it's either ST elevation or ST depression, okay? So if there is ST elevation, which means that the ST segment is higher than the isoelectric line, okay? It is representing a kind of ischemia, okay? Let's call it abnormal, okay? ST segment, if it is ST elevation or ST depression, okay? Now, patient comes with chest pain, shortness of breath, tightness of the chest. You do ECG for him. You notice that his ST is either ST elevated or ST is depressed. You need to work on that as acute coronary syndrome, okay? And then patient has to be complete bed rest, reduce motivation, reduce stress, give him oxygen, and activate a code for, or activate the MI team, okay? or at least call cardiologist. The T wave represents ventricular repolarization, okay? Represent ventricular repolarization. This is the T wave, okay? Now, T wave, normal T wave is equal to around 20 to 25% of the height of the QRS. Now, T wave is affected by two situations: ischemia or potassium abnormality, okay? Now, if T wave gets inverted, associated with ST elevation, you see that in acute coronary syndrome or MI, okay? Always the early representation of MI can be associated with inversion of T wave. Of course, it's going to be associated with ST elevation and T inversion. And as you see here, ST segment is elevated and T wave is inverted. This in this segment, okay? If you look here, T wave is peaked going up. That is hyperkalemia. So in hyperkalemia, T wave gets tall. In hypokalemia, the T wave becomes short, okay? So this is how the T wave is affected by ischemia or potassium abnormality, okay? So you should not ignore that. The QT interval is representing the total ventricular activity. It's the time from ventricular depolarization to repolarization. And in the first presentation, the QT interval was discussed in detail, okay? It is important for us in the critical care emergency department and cardiology clinic and medical clinic, whenever we deal with patients who are suspected to have a QT abnormality, because the QT is affected by a lot of conditions, a lot of medications, okay? Patients on beta blockers, antiarrhythmic medication like amiodarone, some patients on chemotherapy, some antibiotics, ischemia, hypertrophy can cause a QT abnormality, okay? And we have to calculate the QT and the QTC. What do you mean by QTC? QTC is a corrected QT to heart rate, because tachycardia, bradycardia affect the QT measure. For the same patient, when they become tachycardic, their QT interval might go longer. Okay, so it is important always to correlate the QT to the heart rate. And we do that in a very simple manner. Simply, we measure the QT time or QT interval from the beginning of the Q to the end of the T wave, and we divide it on the square root of R to R. So you have here three activities. Number one, count number of small boxes between the Q and the T, multiply them by 0.04 to get your QT. Then calculate your R to R, number of small boxes, multiply them by 0.04, and then find the square root of that number. And then you go to your equation and you divide your QT interval by your square root of R to R. You will get your QTC. Okay, now the most important thing that any patient has a progressive prolongation of his QTC longer than 5% gradually, that person is suspected to have certain abnormality in his ECG. Simply, this can precipitate something we call it Torsades D point or polymorphic ventricular tachycardia. Okay, polymorphic ventricular tachycardia, which is going to be covered in the ventricular arrhythmias part today, inshallah. Okay, right. How do we calculate heart rate when we are using ECG strip? Number one, we agreed from the beginning that for all of us, we accept a 6-second strip to be placed in our patient file or is used for interpretation. which means you go from the beginning of a P wave, you calculate 30 large boxes, and then you cut the paper, and this is going to be your sample for interpretation. Okay, now go and calculate number of QRSs. If you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 QRSs, you multiply them by 10. Why 10? Because simply the 6 second is 10% of 1 minute. In order to make the 60 second, you need to multiply it by 10. So number of QRSs, because each QRS is representing a pulse or an impulse. Okay, so number of QRSs multiplied by 10 is gonna give you the number of beats, or you can calculate the heart rate, okay, based on that. So the first method, which is the most simple way to calculate heart rate on ECG, is number of large boxes multiplied by 10, but in one condition. Your paper should be exactly a 6-second strip, not more, not less. Okay, because this is your caliber. فنقص ورقة طولها 6 ثواني فيها 30 مربع كبير، هذه 10% من الدقيقة. فعدد الكيارسز فيها مضروب ب10 هو الهارت ريت. فif you have 8 multiplied by 10, then your beats are 80. If you have 4, then your heart rate is 40. Okay? طيب. Now, we talk about another method now in regular ECG. Okay? We cannot apply this method if your ECG is not regular. How do we measure the regularity? We measure the distance between R to R. It has to be the same in all complexes. Okay? In this method, we take the interval between the two QRSs. So 300 divided by number of large boxes. Okay? So if I have 4 large boxes, then my heart rate is 75. Now, if you have 1, 300, 2, 150, 3 is 100, 4, 75. Okay, so this is exactly how we apply this concept. Okay, or the same way, the same paper, but instead of calculating number of large boxes, you can calculate number of small boxes, but you have to divide them into 1,500. Okay, into 1,500. So we have 3 methods to measure heart rate using the ECG paper. Now, remember that atrial rate is number of P waves. Number of QRSs is ventricular rate. In normal situation where every QRS has 1 P wave, atrial rate is equal to ventricular rate. Okay? We will go to the next part. Do you have any question on the part of the papers and the intervals? If no questions, we can proceed, okay? طيب, excellent. How do we analyze the ECG? Okay? You have to be, number 1, systematic. Second, don't use your eyes only to read ECG. ECG is interpreted by hands, okay? ECG is like kabsa, okay? How do you eat kabsa? You are using your hand, correct? ECG, you have to eat it or interpret it by hand, okay? So that's why you have to have your tools. You should have your ruler, your caliper, your pen, in order to place your hands on the ECG strip in order for correct interpretation. Otherwise, using a snap, okay, shots, and just guessing is not going to get you to the right answer. So be careful about that, okay? Now, the first step, okay, in analyzing heart ECG is assessing rhythm regularity. Okay, how do you assess rhythm regularity? It's either you use a caliper or use a ruler or a piece of paper, and you mark 2 QRSs, and then you need to move from, I see the arrow here, you move between 2 QRSs to the next QRSs. If the distance from R to R is the same, we call it regular. If the rhythm start to vary, then this is irregularity. Okay, and I want you to pay attention always whenever there is an area of irregularity. Make a line here with a pencil and look what is the abnormality between the 2 QRSs. What is happening? Where is the T wave? Where is the P wave? And how they look like. Because any change in the QRS interval that creates irregularity, whether it is narrowing or widening, is an area of arrhythmia. Okay, is an area of arrhythmia. So if I want to look for atrial arrhythmia, I will see changes between QRS to QRS. When we look for certain kind of blocks, there is irregularity from R to R, I will look in that irregularity area. Okay, so be smart, and always when there is irregular interval, try to look and identify what is happening here. When you pick up what is happening here, you will be able to interpret your ECG correctly. Okay, and we apply this same for ventricular rhythm and for atrial rhythm. R to R is ventricular, P to P is atrial. Okay, now assess the rate, the second step. Okay, normal rate is between 60 to 100, which is the action potential of the SA node. If rate is 101 and above is tachycardia. If it is 59 and below, it is bradycardia. 60 is not bradycardia in adults. In pediatric, yes, but in adult, 60 is not bradycardia, or it's normal. Now, next step, identify and examine P waves. You need to look for the P wave. Is it before the QRS? Is it positive to the QRS? Does it come after a complete repolarization of a T wave, which means I have a flat isoelectric line between the T and the QRS, and the P wave is not merging or mixing itself or coming within the T wave? This is important because one of the criteria for atrial P waves, it comes as fused with the T wave. It does not allow a repolarization. Okay. Then after that, okay, you need to look for your PR interval. Okay. Then I measure my PR interval, and the PR interval is from the beginning of the P wave to the beginning of the Q wave. And you need to find the relevancy. Is this PR interval steady or it has variation? Okay, steady or it has variation. And there is something else I want to stress here. Look between the two QRSs, how many P waves do you have? Okay. How many P waves do we have? Because in certain blocks, we have more than one P wave, okay? We have more than one P wave in certain blocks. So we have to be careful about that. Right, QRS, we have to measure the QRS. Noor al-Harbi asking how. Now, look here, you have one P wave, صح? Here, one P wave. This is a long PR interval. No, this is a long PR interval, and there is one P wave. If I will measure this PR interval, I will count 1, 2, 3, 4, 5, 6, 7, 8. 8 times 0.04 is 0.32. Hina, we agreed that the PR interval is maximum 5 small squares. Here I have 8. That is a long PR interval, okay? So the long PR interval is a PR interval that is longer than 5 small squares. هذه PR interval طويلة. النورمال 5 مربعات صغيرة فقط. Okay? Maximum. For this one is a prolonged PR interval. بعدين, are they the same? If you look here, they are the same. They are steady. Because variation of PR interval, يعني اختلاف طول فترة ال PR interval من مربع لمربع آخر، okay? أو من complex لcomplex آخر، لها interpretation في البلوكس. لأنه في البلوكس نقول steady PR interval or variation in PR interval, or there is no relationship between the P and the QRSs. Based on that, we judge the blocks. Okay? So that's why I'm telling you, don't measure ECG with your eyes. Use your hands. Okay? Then the last thing is the QRS. The QRS is measured from the beginning of the Q to the end of the S. Okay, it's not just from the beginning of the R to the end of the R. You have to take the Q and the S in your measurement. Okay, and normal QRS we said is 0.06 to 0.12. Okay, if it is longer than 0.12, then this is a wide QRS. If I will measure this one, it is 1.5 small square. So this one is 0.06. And this one, if you go from here, 1, 2, 3, 4, okay? 4 times 0.04 is 0.16. This is a wide QRS. It is longer than 0.12, okay? So that's why. So in narrow, wide, usually we refer to wide or ventricular conductions, okay, when the QRS is wide. Usually in ventricular arrhythmias, we see the QRS is wide. When the pacemaker is a ventricular pacer, the QRS is wide, okay? In the supraventricular pacers, like in sinus, atrial, junctional, and supraventricular, all of them are narrow QRSs, okay? So this is how we distinguish between upper pacer and lower pacer by the size of the QRS, okay? Now, then we measure the QT interval, which is from the beginning of the Q to the end of the T wave. And then we interpret the significant scenario. I have a patient with abnormal ECG. I will check for signs of cardiac function. We call it stable or unstable, okay? What do you mean by stable or unstable? Okay, clinical presentation. You have a patient come with bradycardia, okay? This patient is conscious, alert, his skin is warm, his pulse is strong, his blood pressure is 120/80. We call it asymptomatic bradycardia. Another patient come with a bradycardia of 45 heart rate, but he is sweating, his pulse is weak, he is lethargic, his blood pressure is 70/40. This is symptomatic bradycardia. So asymptomatic bradycardia or stable bradycardia does not need intervention. Symptomatic bradycardia will need intervention, okay? So this is exactly what do you mean by sympathetic, by symptomatic or asymptomatic. Any patient comes with abnormal ECG, you need to look for clinical picture. Some rhythms are associated with no patient has no pulse, patient is unconscious, patient is unresponsive. This person needs CPR. Okay, so that's why the clinical presentation with every ECG abnormality will determine what is the treatment that we are gonna do for that patient. Okay, clear? Okay. طيب. Do you have any question about the steps of interpretation? واضحين? Are they clear? طيب. Let us apply them here. Okay. Now, in this rhythm, what is the rate? I will go. Yalla, count with me. 1, 2, 3, 4, 5, 6, 7. Rate is 70. Okay. Now, is it regular? If I will create a caliber, this is regular. Okay. Who is saying no? Okay. It's regular. Okay. Because they are my slides. I know they are regular. Okay. I measured them before I came here. I'm just kidding. Okay. طيب. So it is regular. Okay. Now, if you will go for the atrial rate, every QRS has a P wave. So atrial rate and ventricular rate are the same. Okay. Now, let's look for the P waves. They are positive. They are before the QRS, and they are after a complete T wave, and they are small in size. So this is a sinus P wave. Does this P wave looks like this one, 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 like this one? The answer is yes. So I have a sinus rhythm. Okay, I have a sinus rhythm. Now, what is my PR interval to exclude first degree AV block? 1, 2, 3, 4. Okay, so 4 small boxes. Okay, 4 times 0.04 is 0.16. So my atrial rate is similar to the QRS, 70 and 70. Okay, my PR interval is normal. Then I will move to my QRS. My QRS is narrow because it measures 1.5 small square. Okay, from the beginning of the Q here to the end of the S here, it is 1.5 small square, which is 0.06. Okay, which is 0.06. So this is a sinus rhythm, or we call it normal sinus rhythm. Why do we call it normal? Because the heart rate is normal. Why do we call it sinus? Because the P wave is sinus. Okay, and there is no arrhythmia here. Okay, so this rhythm is my example. Okay, for every other rhythms I am handling. Okay. Does it need any intervention? Does the patient need any treatment here related to ECG abnormality? The answer is no. Okay, the answer is no. Yeah. Let's go for the next rhythm. Let's calculate the rate. 1, 2, 3, 4, 5. What is the rate here? 50. Excellent. So this is less than 60. I'm handling bradycardia. Now, let us see whether it is regular or not. Okay. It is regular. Okay. Let's assume it's regular. Okay. Now, P waves. It's a small P wave after a complete T wave. And it's before the QRS. And it is positive to the QRS. So this is sinus P wave. Is the P wave here looks like the same P wave in all the ECG complexes? The answer is yes. So they are uniform in appearance. This is very important. Look here. They are not peaked. Okay, they are small. Okay, you mean they are like the head? Yes, Sarah. Good. Wallah, you are a good observer. Okay, you are a good observer. Yes, they are شوية peaked. They are not rounded in shape. Okay. Second, what is my PR interval? 1, 2, 3.5. This is 0.0, or this is 0.14. Okay, 14. Still, this is normal PR interval. Is it the same for every complex? Yes. Okay, so what is my QRS? from the beginning of the T here, the R, 1. So I have almost 1.5, okay? Small squares, so this is 0.06 as well, okay? So I am dealing with sinus bradycardia, sinus bradycardia. طيب. Is there any other thing that you notice in this ECG that makes it serious? شايفين شيء غريب؟ ST segment. ماله ال ST segment? ST depression. Yes. This patient has ST depression. This is the S which ends here, and the ST segment is depressed. Yeah. We call it, okay, suspected ischemia, but we need to rule out. ST depression sometimes is caused by other things rather than ischemia. It can be caused by hypovolemia, by electrolyte abnormality, hypocalcemia can do that, okay? So we need to rule out. But we will consider this patient in acute coronary syndrome until we come with cardiac enzymes. Because ST change, but cardiac enzymes are normal and patient does not have other symptoms, is not a big problem. طيب, what are the things that we do for patients with bradycardia? Okay, we have to make sure that this bradycardia is not a new event. This is one. Second, we need to measure patient hemodynamic parameters. We need to see whether this is a stable or unstable bradycardia. So if patient is presented with hypotension, weak pulse, decrease in pulse pressure, his skin is cold, okay, then this patient is symptomatic bradycardia. طيب, what does the symptomatic bradycardia need? Now we know that the sudden decrease in heart rate is affecting cardiac output. When cardiac output is affected, patient is gonna be unstable. Okay? طيب, how do we treat bradycardia if it is symptomatic? We need to speed up the heart. We need to give something to increase the heart rate. Atropine can be used, transcutaneous spacer can be used, epinephrine infusion or dopamine infusion. Okay? Yes, thank you, Mariam. Here, I am dealing with a rhythm. Will apply the 5 steps of ECG interpretation. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. What is the heart rate? $130. Excellent. Is it regular from R to R? It is regular. Okay. Now, yes, 130 is tachycardia. Now, let's look at the P waves. P wave is positive. It's before the QRS and it is round and small in size. So this P wave looks like this P wave, almost the same. All of them are presented as sinus P waves. And they are all after isoelectric pause. شايفين هذا الخط المستقيم اللي على الايزوelectric line between ما بين ال T wave وال P wave? Can you see this flat isoelectric line between the T wave and the Q and the P wave? That means the ventricle has completely repolarized. And that means that this P wave is a sinus P wave. So small, round, positive before the QRS, and it's after a complete T wave. This is a sinus P wave. Okay? Then we will measure the PR interval from the beginning of the P here to the end. If I go 1, 2, 3, 4 small squares, 0.16, and the PR interval is normal. So I have tachycardia, rhythm is regular, P waves are sinus, PR interval is normal and steady, okay, and the QRS is narrow. We are talking about sinus tachycardia, okay? We talk about sinus tachycardia. What are the causes of sinus tachycardia? Sinus tachycardia is always a response, okay, or a compensation. It's either a response to stimulus or a compensation to deficit. Tachycardia happen in hypovolemia, hypotension, and hypoxia, okay? If patient is hypoxic, hypovolemic, or hypotensive for other reason than hypovolemia, patient is gonna be tachycardiac. Second, it is a response to stimulus, okay? Yeah, some medications that stimulate the SA node like epinephrine or dopamine or dobutamine can cause tachycardia. Or it's a response to sympathetic stimulus, pain, fever, stress, okay? Pain, fever, stress. Panic attack is a stress. It's an emotional stress. So it is a stimulus. Here we are not talking about the scenarios. We talk about patient has tachycardia, okay? When patient has tachycardia with normal blood pressure, this is a stimulus. Patient with tachycardia and his blood pressure is low, this patient is a compensation, okay? So this is how you distinguish between stimulus and compensation. I want to remind you your pain score. Your pain score, increase in heart rate and increase in blood pressure are two measures of pain, yes or no? Isn't it? In pain score, we say if patient has increase in heart rate by 10 to 20 and increase in systolic blood pressure by 10 to 20, we consider this positive or added value to the pain score, yes or no? In this case, tachycardia is a response to pain. Same thing with fever, but you need to make sure that this fever is not associated with sepsis, because sepsis is associated with hypotension. Any patient who's hypotensive, his heart rate is going to go up, okay? So that's why once you diagnose tachycardia, you need to look for the cause. If patient blood pressure is not increasing or blood pressure is decreasing, we go to hypovolemia or sepsis or other kind. But if patient is tachycardic, but his blood pressure is going up, that is a stimulus, okay? That's why the treatment will depend on the cause. If a tachycardia associated with shock, sepsis, hypovolemia, the treatment will be volume. If it is associated with pain or fever or not fever, I will put it on the side of sepsis. I don't like to treat fever first. I will correct the cause of fever, then I will treat fever. I am not in favor of treating fever in patients who are suspected to have infection, because fever will help to decrease the growth of bacteria. I'm not talking about sepsis now, okay? It's just focusing on that. Tachycardia with hypovolemia, low blood pressure, patient needs volume. Tachycardia with hypertension or at least increase in blood pressure, that might be a cause of stress, stimulus, or medication. You know, like caffeine, smoking, can also cause tachycardia, okay? Ventolin can cause tachycardia. So you need to look for the cause of tachycardia by whether patient is stable or unstable, okay? So be careful with that. طيب. Let's look for this rhythm because we have limited time now. We are approaching the end of the presentation, okay? This rhythm, is it 1, 2, 3, 4, 5, 6, 7? Rate is 70. ممتاز. Now, is it regular? No, it is not regular. If you look here, this area is wide, this one is shorter, this one is shorter, then it gets longer, then gets longer here, then gets longer there, okay? It is irregular rhythm, okay? Let's look at the P wave. P wave here is small, positive to QRS, before the QRS, and after a complete repolarization. So I have a normal T wave before that, okay? Same here, same here, same here, same here, same here, same here. So all P waves are sinus. In this irregularity, do I have any other P wave? The answer is no. I have only one single P wave between two QRSs. So if I will circle this, I have a PQRST, 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 PQRST. So all the rhythm is sinus, but there is one abnormality, which is irregular R to R. That's why we call this sinus arrhythmia. Okay, that's why we call it sinus arrhythmia. Okay, clear? So in this sinus arrhythmia, it can be physiological, which means when patient takes a breath, his heart rate slow down. When he exhale, his heart rate will speed up. There are people, according to the book of physiology, their phrenic nerve is connected to their vagal nerve. Whenever they take a breath, the stimulation of the breath is going to stimulate the vagal tone, and when you stimulate the vagal tone, heart rate decrease. When they exhale, the stimulus disappear, and then heart rate speed up. This is what we call it sinus, okay, physiological sinus arrhythmia. And there are other pathological, okay, the duration become longer. That's why if someone has tachycardia, especially in panic attack, we'll go back to the panic attack. If you have someone with panic attack, you take them to take a deep breath and hold it. That's gonna decrease the heart rate down, okay? And we use this in SVT as a treatment, okay? We ask the patient to take a deep breath and bear down, create a pressure in his thoracic cavity in order to stimulate his sinus. Okay, Ahmed is asking, what is the difference? Let me take your question. If difference between R to R is small than 2 square, only it is irregular or irregular. طيب, okay. To answer your questions, we have two other sinus arrhythmias. Okay, we have two other sinus arrhythmias. One of them, we call it sinus exit block. Okay, we call it sinus exit block. هذا أحمد. Okay, if you have regular ECG, like regular, all the QRSs R to R are regular. Okay, they are regular. But in one occasion, the difference between the two QRSs is exactly equal to two intervals. يعني you have a missing QRS here. Okay, you are a missing QRS here. We call it sinus exit block. Okay, we call it sinus exit block. If the duration in that area is longer than 2, we call it sinus arrest. But if I will refer to your question, if I understood it very clear, if differences between R to R, two small squares only, That is, we call it sinus exit block. Okay, you will see majority of the rhythm R to R is regular except for that interval. Okay, you have, we don't say two small squares. Okay, it's not two small squares, R to R. Now it will never be two small squares. We talk about longer duration. Okay, we could talk about longer duration because the difference between R to R, okay, if the heart rate is 300, will be one large square, not small squares. That's impossible. You know what does the difference between R to R, two small squares? The heart rate is more than 1,000. Okay, that will never happen. Okay, that will never happen. You will never see that. Okay, we talk about two large squares. The heart rate is 150. Okay, but here we talk about the variation between R to R. Okay, it's either irregular but vary in all the QRSs. That is a sign, that is a regular, that is a sinus arrhythmia. If you have a sinus rhythm, all are regular, but you have a difference between R to R is equal to two intervals, we call it sinus exit block. And if it is longer than two intervals, we call it sinus arrest. Okay? طيب, what is the treatment of sinus arrhythmia? If it is interfering with the hemodynamic stability, okay, we give patient atropine, we connect them to transcutaneous spacer, and okay, and this majority of people who have pathological, okay, sinus arrhythmia, which means it exists in their life for longer period of time and interferes with their life pattern, they will be referred for permanent pacemakers. Okay, they will be referred for permanent pacemakers. Okay, طيب, that is the end of this part. Okay, this is the end of this part, and we have 2 minutes. If you have any question about the interpretation and the sinus rhythms, you can ask them. Other than that, we will go for a break for 30 minutes. Okay? Clear? إذا عندكم سؤال معنا دقيقتين نسأل، وخلاف ذلك راح نروح على بريك. أوكي؟ مدته نص ساعة. Okay? You are welcome. Thank you very much. Okay, enjoy your break. Thank you.
السلام عليكم. جود مورنينج. الصوت واضح؟ الصورة واضحة؟ Okay. Thank you for attending this webinar about the ECG interpretation, analyzing, and thank you for organizing a scientific committee for inviting us to this webinar. And we'll be talking about the atrial and ventricular rhythm. فإذا رح ألخص بشكل شوي سريع عن ال previous session. What are the basic of ECG before going to the advanced rhythm. فنحن in the previous session we were attending or we were focusing on the basic components of ECG, يعني how a normal ECG will look and what are the components. فإذا شددنا على أصل components of ECG. And as you know, we have, in order to proceed with the atrial and ventricular rhythm, we need to know what do you mean by atrial and what do you mean by a ventricular rhythm. And what are, before I will start, but what are the types of waves? نحن حكينا components, or what are the types of waves, or what are the 4 types of waves. حكينا عن ال P, or the P wave, QRSTU. For example, PQRSTU, we call the wave, or what are the components. وقت نحكي عن components or المكونات, they need to be available. Now, if none of them are available, what will happen? يعني if you have, for example, if there is no PQRST or you cannot read it at all, شو يعني? What do you mean? ايش بنعني وقتها كل ال components or wave of the ECG are not available. فإذا this is a life-threatening condition. فإذا هون المريض he is arrested in life-threatening condition. هلا sometimes we might have problem on the P or in the Q or S or T, ST elevation, ST depression, whatever this is, we will see it during the session. فإذا if you are talking about the in this two session, we'll focus on the atrial and ventricular. But in order to determine the atrial rate, how to determine it. حكيناها بالسيشن الماضي. فإذا we will be focusing on the P waves, which is 6 seconds and multiplied by 10. And if you have a, for example, P, we will multiply it by 10 if you have 5 or 6 or 7. And to determine the ventricular, we need to look after the QRS complex in 6 seconds and multiply it by 10. فكان كثير مهم نعرف قبل ما نروح على سيشن الاتريال والventricular that in order to look on the atrial we need to look carefully on the P waves in 6 seconds and multiply it by 10. وطبعا نطلع على الventricular we need to look after the QRS complex in 6 seconds and multiply it by 10. فإذا ومثل ما حكينا الcomponents which are the PQRST, and we will analyze it. It might be sinus, and everything is, or for a PQRST available, or tachycardia or bradycardia, we will see. But then on atrial arrhythmias, what we need, the most atrial dysrhythmias or arrhythmias are not a life-threatening. يعني نحن here, it's not a life-threatening. يعني you might see problem in the atrial, but we couldn't say that the patient he is arrested, or as we mentioned that always we need to look on the patient as patient, not on the monitor. نحن كتير مهمة we are treating or giving treatment for the patient, not to the monitor. How the critical or clinically the patient, how he looks. For sure it's reflected on the monitor, but the patient he is stable or unstable. This is very important. Here, if you are talking about the atrial dysrhythmias, the most of the atrial dysrhythmias are not life-threatening. In the patient, he is stable, or just we need to closely observing the patient. The problem, the heart rate is rapid, may compromise cardiac output. This is the problem that you might see it in the atrial. But then the problem, as we said, in the P appear early, they occur before the next expected beat. نحن حكينا we have PQRST, the only problem that it might happen earlier before the next expected P, and it might be in different P shape wave, and but QRS is normal. مثل ما حكينا بنشدد انه the problem in the atrial is the P. It might be appearing before the next one, or at the same time it might be in different P wave. يعني ممكن تكون مثل ما حكينا it might be in different wave, and you will see it. Especially we will note it during when we put the patient on the monitoring. But on here, early PQRS. What did you notice here? Where is the early PQRS? Let's start with the basic. Here, what do you have? PQRST. PQRST. فإذا مثل ما شفنا هون, but here we have an early P followed by QRS. Okay? فإذا this is what we call the premature atrial complex. It might be as every other bit ممكن تصير bit followed by one. We call it a bigeminy, and every third trigeminy or quadri, or it might be in a couple or pair or whatever, and you will see it here. مثل ما شفنا هون, this is a normals followed by, here we have two, which is if you have two, which has a bigeminy. Okay, three trigeminy. Here we have a couple. We have a three or more together. مثلا this is a pairs, يعني couple, they can هون اجوا مع بعضهم. PQ, as you say, PQRST, يعني all the components you could see it, but here it's come at the pair, and here it might be as, you know, different or paroxysmal atrial tachycardia. Now, what might cause this one? It might be caused by emotional stress, congenital heart failure, myocardial injury, digital toxicity, medication, electrolyte imbalance, hyperthyroidism, and excessive intake of caffeine. فإذا هيدي كلياتها بتشوفوا يعني كثير من الأشخاص بالأخص مثلا إذا بناخذ اللي بيكونوا over stress أو بيكونوا they are taking a lot of caffeine, بحس بيقول لك المريض أنا عم بحس I am feeling like a heartbeat, عم بحس بنبضات قلب سريعة. أوكي, أول سؤال بيسأله الطبيب بحطه على المونيتور, and he might ask him, did you took, for example, if you have a family history, if you have whatever. من addition ممكن تكون نتيجة الستريس, ممكن تكون نتيجة الأخذ الكافيين, عشان كده مش إنه ما تاخده كثير, يعني حسب المتعارف 1-2 cup per day but not too much caffeine. هلا في أشخاص ممكن ياخدوا 10 cup ما شاء الله ما في مشكل, بس إنه it might cause a what we call the atrial tachycardia, أو بحس المريض بنبضات قلب سريعة, which is مثل ما حكينا ممكن نتيجة. مشان هيك بنقول it's not a life threatening condition. فإذا دائما مثل ما حكينا you need to remove stimulation. What was creating, if it's caused by stress, you need to relieve our stress by doing exercising, by walking, by whatever. يعني كل شخص بيكون عنده a different way to release his or to relieve his stress. The collect مثل ما حكينا it might be نتيجة electrolytes imbalance, and sometimes you might refer to the medication for correction. Okay, let's look after this one. What we call this rhythm, what do you think? فإذا نحن أهم شيء we call, if you will count it, we have one, it's regular or irregular. For me it's regular. Let's count it. 1, 2, how many are? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. 18. What is the normal rate? وقت بحكي أنا عن normal ECG, normal heart rate, it's between 60 to 100, 110 maximum. Now I am here 180. This is kind فإذا المريض, what we call this? Okay, this is kind of tachycardia. فإذا هون بعدني عم بحكي ركزوا على البيزك. فإذا هون عم بحكي أنا based on the interpretation, مثل ما حكينا أهم شيء الكومبوننتس are available. Yes. فإذا I could see إنه عندي PQRST, عندي PQR. هلا it's very fast, لأنه rhythm it's very fast. okay I have very fast rhythm. بيكون من الصعب إنه أقدر ألحق الرhythm مثل someone he's running. خدوا مثل العداء اللي عم يركض. at some point you cannot see him. إذا كان هون الرhythm it's very fast, it's available, كل components available, but it will be very hard to detect it. But on I could see that whether components are available. I have the P, I have the QRS, I have the T, I have PR interval, and the QRS it's 0.12. I cannot see it as wide, مش واسع على QRS. أنا ما عندي مشكلة بالventricular. والR والP it's available, it's not يعني converted or whatever. مثلا أنا كل الcomponents والcharacteristic of the components are available. What is the problem here? أنا if I'm counting the R طلعت ما عندي 180. هون I'm not talking about a normal rhythm. ما عم بحكي عن normal rhythm ولا يعني it's not a normal sinus rhythm, and it's not kind of bradycardia for example. Here it's type of tachycardia. Everything is available, but only the rate it's very fast, 180. But this is what's called the atrial tachycardia, and you could see it here. What is the treatment? نحن دايما بالfast rhythm always we need to look after the patient condition. okay فإذا دايما مثل ما حكينا patient condition. Patient if he's stable we need to keep him under close observation. نحن دايما we have 3 types of intervention for the patient: monitor the patient, medication administration, and intervention. okay يعني بهالحالة أنا ما بروح دغري على synchronized cardioversion. First, I will go with the anti-arrhythmias medication. It might be the adenosine or amiodarone or beta blockers, followed by synchronized cardioversion, which is we will see it now. راح نشوفها بالسيشن الثاني. فإذا this is here I'm talking about a patient who is unstable. If I have a narrow QRS and if there is no or no طيب السيشن الثاني هون كمان هير نحن عم نركز بالاتريال، عم نحكي عن الاتريال very fast rhythm. What do we call this? What do you think? This is a SVT. What do you mean by SVT? This is a supraventricular tachycardia. Again حطوا براسكم انه نحن الكومبوننتس we need to look after the components. PQRST here, do you think the components are available? Yes or no? Again, just to call your attention, نحن وقت عم نكون بالcritical care or emergency نحن if you are reading an ECG نحن we are simplified here, but there is no time to go with simply يعني ما بقعد أنا this is the PI, you need to interpret it by your vision. يعني من النظرة بتعرفوا this is a life threatening, this is a pulses VTAC, VF, this is tachycardia, this is يعني طيب هون based on your observation what type of rhythm are we seeing here? فإذا this is a very fast rhythm. The components are available. Do you think the components are available for me? The components are available, but the problem because the rhythm it's very fast here. I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 20. I'm talking about, or I am seeing a rhythm more than 240, 250. يعني it's very fast. It will be very difficult to see the components, but at least here بنشوف انه ال P it's hiding on the T. يعني ما بتلحق ال P بتطلع الا ما بتلبس الا ما بحسوها كأنها T بظهر التي. فاذا الشغله ما لانه الريزم it's very fast. P you could see it as a T. okay بتكون بظهرها للتي. بس QRS you could see. okay فاذا this is what we call the supraventricular tachycardia, and as we mentioned that the P wave it's hiding in the T wave. بتشوفوا ال P كأنها T, but there is P and there is T. But المشكلة because the rhythm is very fast, you cannot differentiate. You could see it as one wave, but it's two different wave, which is P and T. But the problem the P it's hidden or in the T wave. but the QRS, it's normal. Now, again, what do you think? What types of, parasupraventricular tachycardia? It's supraventricular tachycardia that start and type. Now, do you think what type of management do you need to give to such a patient? Again, نحن صحيح عندنا different types of ECG. وعندنا different types of rhythm. حتى بالتاكيكارديا we have different name, but at some point رح تلاحظوا انه treatment is similar. رح نلاحظ انه treatment of such cases are similar. إذا بتشوفوا انه اذا عندي انا atrial tachycardia, supraventricular tachycardia, atrial fibrillation, atrial flutter, رح تشوفوا انه mainly at some point رح تشوفوا treatment is similar. صحيح different wave يعني بس at some point it will be treated as, since there is a pulse شد whatever, so pulse and you have fatilism, رح تشوفوا انه treatment at some point it's similar. مثلا هون دائما what will be the approach of the patient? The patient is stable or unstable. This is the first question that always we need to ask and we need to see. If the patient is, ممكن حطوا أنا على الرhythm أو على الهيمودynamic and I could see it that the patient, the rhythm, it's tachycardia, but المريض he is okay. يعني usually a patient with 250 he's deteriorating whatever, but أنا حطيته على المونيتور I could see that the patient is okay. Again, we need to keep under a close observation because at any second ممكن المريض يكون symptomatic and he might be asymptomatic and he might be symptomatic. Okay. يعني وقت بحكي عن asymptomatic يعني stable، وقت بحكي عن symptomatic patient he is deteriorating or he is in a critical condition. فإذا what will be the treatment here for asymptomatic? Again, stable patient with tachycardia with a palpable pulse can be treated with more conservative measure first. ممكن نعمل vagal manner or cuff method and allow the patient time. فإذا patient stable under close observation. If the patient is symptomatic يعني عنده tachycardia, hypotension, decreased level of consciousness اللي هني أكثر علامات بدلوني إنه المريض he is in a shock. اوكي يعني مريض عنده وقت بحكي عن instability يعني tachycardia, hypotension, decreased level of consciousness، ساعتها انا المريض if he's symptomatic فإذا he has a symptoms يعني he needs to give a synchronized cardioversion. Okay, followed by if anesthetical administered adenosine 6 mg. بنروح هون دائما على الميديكيشن which is the adenosine 6 mg adenosine 12 ملغ followed by a synchronized curve. مثل ما حكينا فاذا دائما انا بروح على closely observation of the patient, medication treatment and procedure. هون بروح انا فاذا the first line of treatment I need to start with a مثل ما حكينا with a medication treatment which is the adenosine 6 mg, adenosine 12 mg followed by a synchronized cardioversion which is mainly between 50 to 100 joules. اوكي as recommended. دائما بنروح حسب الريكومنديشن تبع ال AHA او الامريكان هارت اسوسيشن. فاذا هيدي المعلومات it's not our, it's from the as recommended by the AHA or American Heart Association. Now again برجع بقول لكم نفس الخبريه انه وقت بحكي انا عن التاكيكاردياك ريذم رح تشوفوا انه similar treatment بس ما ممكن تشوفوا few differentiation. But here, if I'm talking about atrial fibrillator, في كتير أشخاص يعني based on our experience بيضيعوا بين الاتريال فلاتر والاتريال fibrillation يعني but you will see what are the similarities and what are the difference between these two. فإذا وقت نحكي عن الاتريال flutter your heart upper chamber الاتريا تكلمنا عنها beat too quickly. هون عم نحكي عن very fast rhythm which is caused the heart to be fast but usually it's a regular rhythm. شو لاحظنا؟ هون الرhythm it's very fast بس أنا لاحظت تذكروا هيدي but الرhythm it's regular يعني بنشوف it's الار اتس ريجولار، ما عم بحس انه الار بعيده عن اكثر من ثانيه. فاذا هون بعدني very fast rhythm because the atria يعني very quick, which is causing the heart rate or the heart to beat in a fast way, but usually it's regular. هون ذكروا لانه اذا بالاتريال flutter it's regular، بالاتريال fibrillation مش رح تكون regular، رح تكون irregular. هون بدي بلش انا اعرف الفرق. برجع بقول لكم ركزوا على، انا عم نجرب نعطيكم a practical session لانه بالكريتيكال كير بالامرجنسي impatient who is arrested والdeteriorating ما بيكون عندي وقت فوت بالتفاصيل المملة. I need to interfere. فإذا very important to know about it. الاتريال فلاتر مثل ما حكينا الريت كله عم نحكي عن very fast rate here. شوفوا عم نوصل 250 to 350 beats per minute. اوكي الريزم اتس ريجولار، كمان ركزت بالفلاتر that the rhythm it's regular. P يعني it's non identifiable P waves كمان لانه very fast. ال PR I cannot measure it، يعني انا بقول لكم هون وين ال PR او ال PR interval I cannot see it. اوكي and the QRS it's less than 0.12 seconds. فاذا very fast rhythm but it's regular but أنا I cannot identify because the rhythm it's very fast. the P wave ما في يعمل identification وال PR not measurable لأنه I cannot identify it because the rhythm it's very fast. أنا عم نحكي هون على 250 to 350 bits per minute. شو الكوز تبعها؟ لحظة إنه معظم المرضى this is the mainly cause of pulmonary embolism. معظم المرضى pulmonary they end with this type of rhythm. ischemic heart disease, hypoxia, and toxicity to medication. فإذا the severity of signs and symptoms vary depending on the main danger with atrial flutter, and congestive heart attack and stroke can result. كثير مرضى هون they might have with a stroke because of the blood clotting. أنا أتذكروا برجع لكم عم بحكي pulmonary embolism، تجلطات الرئوية. أوكي فإذا هون أكثر شيء يعني just to be sure about the blood clot. The goal of atrial flutter treatment is to control the heart rate in order to prevent stroke. فإذا أكثر شيء بخاف من قصة الاتريال flutter blood clotting هي المريض he might end with a stroke. management again برجع بقول لكم شفتوا يعني من stable patient هون انا have 350 rhythm ما في اكيد ما راح المريض يكون 350 bit per minute وستيبل. اوكي here we will start with the anti-arrhythmias medications, amiodarone, calcium channel and beta blockers, heparin and digoxin. heparin ذكر عم نحكي عن clotting و pulmonary embolism والى اخره. if the patient is unstable هون it's asynchronous. شو لاحظتوا؟ يعني شو لاحظنا بكل الاشياء اللي حكينا هون؟ حكينا عن الانتي اريثميا ميديكيشن سواء اميودارون والدايجوكسين والى اخره، وحكيت عن السينكرونايز كارديوفيرجن اللي هي شغلتها جست تهدي الريذم. مش عم بحكي انا عن الشوك. الشوك رح نشوفها بالفنتريكولر رح نشوف هون. فاذا المين تريتمنت تبعها just to stabilize the patient by going a synchronized cardioversion. amiodarone إذا رحنا 150 mg over 10 minutes followed by 360 mg over the next 6 hours. Then 150 mg over remaining 18 hours infusion طبعا. فإذا total of 1000 mg over 24 hours before administering the maintenance. atrial fibrillation. شو لاحظتوا الفرق هون بين الاتريال fibrillation والاتريال flutter؟ What kind of difference did you notice between atrial fibrillation and atrial flutter؟ شو لاحظتوا الفرق؟ ليش لاحظتوا الفرق؟ قلت لكم اياها قبل. I gave it to you as a tips before. No P wave. excellent. مثل ما حكينا تشوفوا انا عم بقول لكم شو الفرق. نفس الشيء. P it's I cannot see it, it's absent, I cannot detect والى اخره لانه very fast rhythm. بس انا شو لاحظته؟ شو الفرق؟ انا بدي اياكم تعرفوها من النظر. هون it's irregular، هونيك كانت regular. الار مضبوط. اذا برجع على الرزم ليش قلت لكم ركزوا؟ لانه اللي قبل كانت it's regular، هون irregular. الار here it's not same ار. وهون بتشوفوا يعني كمان بتحسوها زي المنشار، زي النايف، رأس النايف. شوفوا اتس يعني كمان. فاذا this is atrial fibrillation رح تشوفوا but in term of treatment and وطبعا الويف it's different. هون this is what we are talking about. No P wave and it's irregular rhythm. This is the بعدين هونيك ال P I cannot detect undetectable it's but هون no P wave but I have a irregular rhythm. كمان what will happen يعني what will be the line of treatment. My goodness, my dear, 300, 600 يعني you couldn't imagine how much 300 to 600 bits per minute. And شو الكاركترستيك مثل ما حكينا كمان again عم بحكي عن blood clotting formation. فإذا you will see that يعني مثل ما P wave I cannot see it not available, PR not measurable, QRS and irregular. رح تشوف إذا بترجع بالحالتين ال PR or how do you it's very hard to detect لأنه الرزم it's very bad. هون كيف بقدر ميزهم؟ إنه أهم شيء شوف أنا it's irregular. وقت بشي على اللاين الكوز it's mainly كمان coronary artery disease, congestive heart failure, drugs, hyperthyroidism, pulmonary. شفتوا عم برجع pulmonary embolism. Now always we need to check the patient. فإذا it's very important to check the patient. كمان شو لاحظنا؟ same line of treatment, anti-arrhythmias, amiodarone, calcium. شفتوا عم بحكي على نفس line of treatment تقريبا. atrial fibrillation, atrial flutter, and unstable we need to go for synchronized cardioversion, which is a painful and the patient needs to be or sedated and يعني it's low voltage of electricity but مش شوك، بنعتبرها كشوك مثل ال. فاذا طيب what did you understand؟ شو حكينا عن الاتريال؟ شو الاشياء اللي لازم نعرفها عن الاتريال؟ فاذا what do we need to know about the atrial قبل ما نروح على الفنتريكولار؟ فاذا in order to resume فاذا الاتريال P problem the rhythm it's very fast rhythm. It will fall under the tachycardiac rhythm. We have different types. وأنا بحكي عن الاتريال tachycardia, supraventricular tachycardia, atrial fibrillation والاتريال flutter. ايش الشيء القاسم بيناتهم هو؟ ايش هو المشترك؟ very fast rhythm لانه الريزم is very fast at some point انا ما بقدر اشوف وين البي ولا ما بقدر الكومبوننت ما بتكون واضحه بالاخص البي ات مايت بي مثلا اذا شفنا بالسوبر فنتيكولار تاكيكارديا هي اتس هيدن اون ذا تي يعني بتشوفوها هي مثل كانها ملزقه بالتي. وقت بحكي اتريال فيبريشن اتريال فلتر كمان at some point مش موجوده او I cannot detect it at all. الفرق بيناتها وحده the rhythm is regular and the rhythm irregular but in term of line of treatment لاحظنا انه اعطينا الانتي اريزمياز ميديكيشن والسynchronized cardioversion. فاذا الاتريال close observation patient is stable بلش medication treatment followed by intervention وبساعتها I will see because the patient at any time as I'm here the patient at any time he might go for at any time the patient here he might go from he might be يعني طب هون انا بس في شغله كثير مهم نعرفها انه هون الكونديشن الوحيده انه I am with the patient انه there is a rhythm. وقتها because there is no rhythm يعني انا ممكن عندي اتريال تاكيكارد or you know ventricular or ventricular tachycardia or whatever بس انا ما عندي rhythm هون بساعتها I need to go for shock. روح على patient who will be under 2. Clear about the atrial قبل ما نروح على الventricular? Do you have any question about the atrial rhythm before going for the ventricular? If there is no question, give me 2 minutes just to change the slide وحنكون مع ال ventricular rhythm. اوكي دقايق بنكون مع ال ventricular rhythm. Okay, good morning again. And next part of the session is the ventricular. فإذا حكينا atrial P, ventricular. Now, what we mentioned QRS. We will see now what do you mean by a ventricular. and لأنه بعد بدي أعطيكم يعني like a code وإلى آخره. Just I will go to the main part which is idioventricular إن شاء الله حتكون بعد الظهر. And I will go to the ventricular tachycardia. Now, هذا كثير مهمة. Just even if you attach the patient to the monitor with any type of rhythm, you need to check the pulse, if that pulse is available or no. If there is no pulse, patient is coded, arrested. If there is pulse, we will see if they're weak or pulse or whatever, and patient will be under close observation. And you will see if it's a very fast pulse, tachycardia, it will be treated as tachycardia already mentioned. If it's a very slow bradycardia already mentioned, and I think we have afternoon session talking about the bradycardia and about the block. بس أنا حركز هلا على موضوع الفانكولار الفيتك. Now, when we categorize the rhythm, we categorize under 3 or 4 categories. We have the tachycardic rhythm, we have the bradycardic rhythm, we have a shockable rhythm and non-shockable rhythm. يعني وشو بحكي وقتها بعطي الشوك؟ امتى حسب رايكم بعطي الشوك؟ الشوك وقتها ببلش انا ما عندي pulse at all, there is no pulse. يعني انا ممكن هون شوف رhythm زي هون ventricular tachycardia. Okay, all the components are here. يعني ممكن شوفه انا like rhythm وباخد ال pulse of the patient and the pulse is available والpulse is موجود. فإذا here it will be treated as the ventricular tachycardia. ما في يعمل وقت يكون عندي pulses فيتاك، عندي هيدا rhythm but there is no pulse. وقت بحكي أنا كلمة pulseless means no pulse. Okay, just for you to know, pulseless means there is no pulse. هون أنا عم بحكي عن simple ventricular tachycardia. عندي هيدا الرhythm and where the QRS complex is wide, P waves it's visible, bear no relationship. أنا شايف ال P but مش there is no relationship between the P and the QRS, but the rhythm it's regular. At some points ممكن يكون irregular but mean it's regular. But here أنا عندي pulse. Okay, this is what we call a ventricular tachycardia. It might be monomorphic VTAC or polymorphic, And here, what are the causes? It might be sustained monomorphic beta associated with many, it might be cause. طبعا it's related to heart disease and myocardial ischemia and يعني what are the other causes اللي حكينا أمراض القلب والشرايين cardiomyopathy, valve problem, myocardial contusion, acid-based imbalance, electrolyte imbalance. كثير شددنا على electrolyte imbalance. كمان it might cause hypokalemia, hyperkalemia, and hypomagnesemia والى اخره. هيدي كلياتها بتسبب الاسباب اور في تاك. بس دائما في كثير بدنا نركز نفصل بين البالسس في تاك والفي تاك. الفي تاك you will see this is the cause and this is the symptoms اللي بتوريني انه المريض in addition he might have a يعني بيجي المريض على قسم الطوارئ complaining of chest pain, hypotension, shortness of breathing, pulmonary congestion, heart failure والى اخره. Now كمان هون اهم شيء هون نقطه. ليش بقول لكم just we will not treat the machine لانه اذا شو فيكم هيك لازم رح تقولي لي ventricular tachycardia go for shock. لا. Always I need to look for the signs. I need to look on the patient first. هون انا عندي فيتاك بس انا كيف بحدد اذا pulses or non or ventricular or pulses VTAC? By checking the carotid pulse. Now, if there is pulse, you know if it's stable amiodarone, if you have posadopontis magnesium, or unstable synchronous. يعني إذا لاحظتوا at some point it's treated under the atrial or under the tachycardiac rhythm. But هون إذا المريض there is no pulse ساعتها أنا it will be coded. يعني بدي أروح على اللي حنشوفها بالسيشن الثاني اللي هي السي بي ار والديفبريشن ابنفرين اكسجين اند انتي اريزمياس ميديكيشن. فاذا دائما بيختلف الموضوع عندي وتذكروا هذا الريزم لانه بالنكست سيشن رح نروح على التريتمنت تبعها. يعني مش رح فيكم تشوفوا الريزم اللي حتشوفهم. فاذا this is what we call a VTAC. VTAC it will be treated as tachycardia من الاميو انتي اريزمياس ميديكيشن synchronous cardioversion and under close observation. But if a pulse VTAC ما عندي pulse it will be coded data it will be a shockable. وقت عندي هون هيدا الريزم and there is no pulse we call it a pulse VTAC and it will be need to give a shock أو الصدمة الكهربائية. مثل ما حكينا it might be هون ال QRS هي it's more than 0.12 seconds. بتلاحظوا انه it's wide واسع and it's difficult to differentiate between QRS and T-wave. ما بقدر يعني ال P it might be present or it might be absent and at some points ما بقدر لاحظ انه there is a relation between PP and QRS. هون it might be polymorphic. طيب طيب هون فاذا هيدي البالستس فيتاك. ventricular fibrillation كيف could you interpret the rhythm؟ طيب هون اذا بدنا نشوف على هذا الريزم what could you see in this rhythm؟ شو شفتوا بهذا الريزم؟ اول شيء اغلى شيء regardless what type of rhythm بدي اخذ انا البلس تبع المريض. what did you see here؟ شو لاحظتوا بهذا الريزم؟ irregular. ايش غير؟ polymorphic. what else؟ يلا مشاركة أكثر لتقدر تستفيد. irregular polymorphic. what else؟ wide complex. شغلي طيب where is the P؟ حدا قادر يشوف البي هون؟ are you able to see the P؟ excellent. are you able to see clearly QRS؟ are you able to see the P؟ ممكن تشوفوا ال PR interval، ممكن تحددوا ال RR it's regular or irregular أو يعني هون مثل ما حكينا ما في أي شيء واضح. no P. QRS sometimes يعني ممكن نشوفه ممكن ما نشوفه. no T, no PR interval, nothing. يعني زي مريض ما عنده أي vital sign. nothing here. أوكي. هون إذا عندي هيدا الريزم and there is no pulse, we call it a ventricular fibrillation. This is فإذا المريض هون he is coded, he is arrested, and I need to initiate the code and start line of treatment اللي حنشوفها في السيشن. لو سمحتم هون لو تكرمتم بس ركزوا على هيدا الرزم لأن رح تقطع معه وقت بشوف فيكم بعدين البالسز بتاعك والفي اف just to know how we could differentiate. Okay. فإذا this is the ventricular rhythm. هيدي ممكن تشوفها مثل ما شفنا هون. يعني هوليك يمكن الصورة أوضح هون مثل ما شفتوا. ما بقدر I cannot detect anything. ما بقدر أشوف أي components من ال ECG. بدي أحط لكم إياها more time just to تشوفوها لأن رح تقطع معنا بالسيشن الثالثة وقت بنعمل interpretation للريزم. And this is مثل ما حكينا always check the patient before beginning treatment of ventricular يعني fibrillation. The patient if is unresponsive طبعا المريض وقت بيكون يعني ولا ممكن نشوف مريض بهيدا الريزم وهي conscious oriented. He is unresponsive, no pulse, apneic, pulse there is no pulse and he is arrested مثل ما شفنا. فإذا الريت ما بقدر أعرفها cannot be determined because there is no waves or complex to measure. الريزم rapid, no pattern, regular, irregular ما أعرف. P I cannot see it. PR I cannot and QRS كمان هذا السين. شفتوا كل الاشياء الكومبوننت كل اللي شرحناهم بالنص صباح مش موجودين ولا اي كومبوننتس منهم. فاذا هون plus there is no pulse. فاذا here the patient he is in shock condition. وتذكروا line of treatment because we are going to talk about the line of treatment in the next session إن شاء الله. Cause it might be a factor from inside or factor from outside. فإذا here the outside extrinsic factors, vagal stimulation, metabolic abnormalities, and anti-dysarrhythmias and other medication like psychotropic, digitalic, and electro and symptomatic, and some of the intrinsic factors like hypertrophy, ischemia, myocardiac failure, and severe bradycardia. Ventricular fibrillation intervention مثل ما حكينا it will be by going for code. يعني patient he might go for defibrillation والسي بي ار والشوك والابينفرين والى اخره اللي حنشوفها ان شاء الله بالسيشن الثاني. هون عندنا another two session asystolic. فاذا عندنا الشوك قبل حكينا عن البراديكارديا او حكينا عن التاكيكارديا. هون بدنا نحكي عن الاسيستولي. What did you see in the rhythm here? كيف ممكن تشوف هيدا الريزم؟ How would you see it? What is the problem here? Where is the P? Where is the QRS? Where is the T? What is the PR interval? What is the RR? وين الكومبوننتس هون؟ طيب here فإذا ايش الفرق هون بينه وبين ال VF ventricular fibrillation؟ فإذا هون flat interval. فإذا وقت بتقولوا لي flat interval إنه مريض passed away. يس وقت بحط المريض هيدي معروف حتى اذا ما كنا زي ما بنقولوا كممارسين صحيين نحن بنعرف انه مجرد ما نشوف فلات خلص patient he pass away. Yes, he is a patient pass away. لا we need to double check. فإذا هون إن كانت asystole we have line of treatment، بس هون ممكن المريض يكون disconnected، يعني يكون الالكترود مثلا مش مكانهم. اوكي رح يطلع عندي ممكن شو المريض عم يضحك قدامك هي stable oriented but there is flat line. هل يعني انه المريض he pass away for sure. We need to check the leads of the ECG. But here in case the patient has a systole فإذا we will see the line of treatment here which is مثل ما حكينا which is here أول شيء الكوز it might be pulmonary embolism, tension pneumothorax, hypovolemia. نحكي على 5H and 5T. tension pneumothorax, hypovolemia. This is a very long ECG هو very long session يعني ممكن نقضي يومين but أنا I need to go to the main point. فإذا tension pneumothorax 5H اللي هي hypovolemia, hypoxia, heat cold, hypokalemia and myocardial 5H وال 5T مثل tension pneumothorax, tamponade والى آخره. intervention confirm أول شيء مثل ما حكيكم دائما I need to check the pulse, perform the CPR, confirm the rhythm in 2 leads. Patient he might go for intubation. For this reason we need to put a IV access, and always we need to see what are the cause of this rhythm, which it might be 5H and 5T as we said. وهون كمان PEA pulses electrical activity. What do you think؟ شوفوا شو challenging here. What did you see the rhythm؟ شو المشكل هون؟ PEA pulses electrical activities. يلا who could interpret the rhythm؟ طيب خليني اروح اعمل interpretation وشوف. طيب خليني اشوف هون. شوفوا رح انا I will go with the basic PQRST PQRST PQRST. كل الكومبوننتس موجوده 1 2 3 4 5 6 7 8 9 10 11 12 13 14 يعني ممكن يكون رقم 100 around 150 بس انا شايف كل الكومبوننت موجوده اتس ريجولر. فاذا وات از ذا بروبلم؟ شو المشكله هون؟ عندي كل الكومبوننتس واتس ريجولر ومش تو فاست ولا سلو within the normal range. ايش المشكله هنا؟ هون مثل ما حكينا انا لازم شوف على قصه كل شيء نورمال بس هون المشكله there is no pulse. انا ليش قلت لكم ما نروح على الريزم بلا ما نكون شيكنا على البلس؟ ثانك يو. اذا بدي شيك على البلس. here there is no pulse. هون ما فينا يعني هون we have this is the same as line of treatment as asystole. asystole PEA we have the same line of treatment which is the CPR treating the cause and epinephrine. رح نشوفها بالسيشن الثاني. cause pulmonary embolism مثل ما حكينا مثل ما لاحظتوا الاسيسول PEA it's the same problem and the same cause which is مثل ما حكينا 5H and 5T and the same line of treatment اللي هي مثل ما حكينا اللاين اوف treatment اللي هي بتركز على قصه ال 5H وال FT اللي هي الابنفرين وهي ال CPR و treating the cause سواء كانت 5H or 5T. فإذا begin CPR go for intubation, search for possible cause and medication per current resuscitation guideline are epinephrine. Any question about the ventricle قبل ما نروح على السيشن الأخيرة؟ بعرف اليوم it's very يعني كتير tough عليكم وكتير من المعلومات but يعني it's good for you just to know all this information. Any question? طيب give me 2 minutes. بعدنا بنفس السيشن بس بدي أعطيكم هلا سيناريو. Okay, give me 2 minutes just to share the slide and I will be with you. أيوة السلام عليكم. ممكن تشوفوني تشوفوا السلايد بشكل واضح؟ Are you able to see the slide? اوكي طيب فاذا رح نختصر mainly اللي فترة الصباح بهيدي يعني was a practical session in order for you to know what are the how to treat a patient. طيب وتحكينا عن الريزم فإذا صنفناهم براديكارديا not treated رح تروح على البلوك، تاكيكارديا كمان supraventricular tachycardia flutter وفبريشن وحكينا عنها what are the treatment. البراديكارديا مثل ما حكينا ان شاء الله فاتت بعد الظهر نحكي عن البلوك مع الدكتور وبيرجع عنا الفنتريكولر اوريدي تكلمنا عليها كلمتكم عنها والحين رح نعطي example what will be the treatment يعني what will be the treatment. حدا عم بيقول لي زوم ان what do you mean by zoom in؟ انا بالنسبه لي everybody عم يقدر يشوفني بشكل كويس. في حدا عم الاخوان عم بيقول لي زوم ان بليز what do you mean؟ عم تقدروا تشوفوا السلايد بشكل واضح يا اخوان؟ اوكي طيب طيب فاذا هير انا وقت حكينا عن رح ركز على قصه الشوكبل ريزم وتحكينا عن الفنتريكولار الا وهي مين ان الريزم which is we categorize as a ventricular rhythm قلنا الشوكبل يعني البالسلس في تاك اند في اف واوريدي فرجيتكم اياها بالسيشن الماضيه انه what how would you see a pulseless VTAC and VF ودائما ركز على قصة البلس. فإذا let me give you a case scenario and to see what to do. You have a patient admitted through the emergency department or came to the emergency department and the patient he is unconscious, unresponsive. Whereas the patient he is unresponsive. Whereas the patient he is not responding. Okay. Now what to do؟ شو لازم نسوي؟ اجى المريض على قسم الطوارئ he's brought by ambulance patient he is unresponsive. شو لازم نسوي؟ أول شغلة وأهم شغلة أنا I need to determine وقت المريض بيكون unresponsive by default بيروح على وين؟ على الكود روم. He's coded. Now I need to check the pulse. If there is no pulse, now I will start immediately CPR and I will give oxygen and attach the patient to the monitor because I need to see what type of rhythm. بدي أعرف أنا شو نوعية الرhythm عند المريض is shockable or non-shockable. هون أهم شيء أعرف shockable يعني زي البالسز فيتك والفي اف والنون شوكبل مثل اسيستولي والبي اي. فاذا هون عندي وقت بحط البيشنت على المونيتور بصير عندي انا فكره انا كيف يعني بقدر. فاذا شوكبل وقت بكون عندي شوكبل ريذم، اوكي، وقت بيكون عندي شوكبل ريذم there is no pulse الكود تيم بيجي it's 5 people 5 اشخاص اللي هن الكود تيم ليدر. One responsible for the shock, one is responsible for CPR, one responsible for the airway, one for medication, and one for recording everything. إذن هيدي الأشخاص اللي هن they need to be available during the call. الكود team leader هو اللي بيحرك الكل. بيرجع عندي one is responsible for the airway الأنبو باجينج, one is responsible for CPR and one to give the shock. وحدا بيعطي الميديكيشن and one will be giving will be recording everything. فإذا since the patient I detect him as shockable rhythm I need to start the first shock which is 200 joules. وقت بعطي أنا للمريض pulse فيتك NVF 200 joules شو نسوي بعدها followed by CPR. قديش بنعطي CPR هنا who knows. فإذا أعطيت أنا الفيرست شوك لأنه المريض عندي pulse فيتك or VF I give him the shock followed by I give him the first shock followed by CPR. CPR قديش مدتها 5 cycles 2 minutes 30 to 2 يعني 5 cycles 2 minutes. بس خلص أنا من الأول شوك I will what to do I will check the pulse. برجع بشيك دايما البلس. اليوم ركزت عليك I will check the pulse. There is no pulse second shock. Meanwhile وقت بعطي أول شوك الميديكيشن نيرس she will be preparing the epinephrine بس ما بنبلش نعطي إلا على السكند شوك. اوكي فإذا بنفضل أول شيء على الابنفرين ونبلش نعطي على الابنفرين بالسكند شوك. كيف نعطي الابنفرين؟ 1 ملغ every 3 to 5 minutes. فإذا كل 3 دقائق مش ضروري أنا على طول يعني عيد الخبري الميديكيشن نيرس إنه أعطيه سي بي ار ابنفرين كل 3 to 5 minutes بعطي 1 ملغ. فإذا first shock 5 cycles 2 minutes no pulse. Second shock 5 cycles 2 minutes. Third shock 5 third shock بهالوقت بيكون الابنفرين every 2 to 5 minutes and this is the فإذا in between الابنفرين is going on and after this one I will do the not anti-arrhythmias which is the amiodarone or lidocaine. amiodarone هي مثل ما حكينا 300 ملغ bolus as to dose and فإذا what are the line of treatment تبع الشوكبل rhythm pulse VTAC or VF no pulse shock 5 cycles من CPR. كمان بشيك على البلس. فإذا 200 300 360 joules. In between بيكون عندي 5 cycles 2 minutes. In condition there is no pulse. وات the end وقت بعطي الابنفرين in between 1 ملغ every 3 to 5 minutes والمريض بعطي الانتي arrhythmias medication which is the amiodarone or lidocaine and always I need to treat the cause. طيب بروح أنا على النون شوكبل. شو بنعني بالنون شوكبل؟ مثل شو تكلمنا عنها الاسيستولي and the PEA. asystole and the PEA. طيب بالاسيستولي والPEA شو هي الكاركترستيك واللاين اوف تريتمنت؟ فرجعتكم اياها انه بالاسيستولي انا في عندي فلات لاين، فلات لاين ما بيعني انه المريض توفى، يعني ممكن يكون ديسكونكتد. والبي اي او البالسد الكتريكال اكتيفيتيز انا كل الكومبوننتس اتس افيلبل عندي اللي بي كيو ار اس تي والار ار انترفال كله but there is no pulse. What to do in this case? Line of treatment it's similar to the يعني بس ما بنعطي شوك، لانه الشوك بس بعطي بالباسد فيتاك ان بي اف. هون اي في اكسس وبنعطي ابنفرين 3 to 5 minutes وتريد تاكوس. فاذا سي بي ار تريد تاكوس and epinephrine 3 to 5 minutes. وضحت الفكره هون يا اخوان؟ فاذا وضحت انه انا عندي الشوكبل والنون شوكبل، هيدي كله بناء على الريذم اللي فرجتكم اياهم قبل. طيب هذا اول كاتيجوري اللي حكينا الشوكبل. هلا بنروح على الكاتيجوري الثانيه اللي هي مثل ما شفنا هون، اللي هي البراديكارديا. كمان تذكروا الرزم، وقت بنحكي عن البراديكارديا شو اهم كومبوننتس؟ يعني ذا ريزم اتس سلو، عندي مشكل انه الريزم تبعي او البالس اتس فيري سلو، موجود الكومبوننتس بي كيو ار اس تي والبي ار كله هون. طيب كمان وقت عندي البراديكارديا تذكروا شو تكلمنا انه always في عندي شغلتين that I need to monitor the patient because the patient he might be stable or he might be unstable. شو الفرق؟ stable patient keep under close observation because at any time he might be unstable. Unstable اللي هي bradycardia، اللي هي hypotension، اللي هي decreased level of consciousness. If I have a patient with a bradycardia with a unstable bradycardia يعني عنده hypotension decreased level of consciousness، انا رح ابلش هون مثل ما حكينا تذكروا اللي احنا بنروح على الميديكيشن تريتمنت وفولو باي انترفنشن. ميديكيشن تريتمنت هون بلش بالاتروبين and dopamine and epinephrine and وبساعدها بنروح بعدين على النات تريتد وبعده البالسس عم ينزل، بساعتها بنروح على البلوك هذا اللي حنشوفه ان شاء الله بفتره بعد الظهر اخر سيشن. اذا هون وقت بحكي انا عن البراديكارديا اختصرنا الرزم كلياته. البراديكارديا الرزم فهمتوها شفتوها كيف، بس وقت بحكي عن التريتمنت كمان هون بدي اعرف انه انا ما I cannot treat the machine, I need to treat the patient عندي stable observe لانه at any time ممكن يصير unstable. كيف بعرف انه unstable؟ فجأة المريض hypotension وصار في عنده decreased level of consciousness وصار في عنده hypotension sign of shock. شو بعمل؟ ساعتها ببلش الرزم just to سرع الرزم، ببلش بالاتروبين. اذا حسيت ان الاتروبين اتس ineffective مش فعال بروح على الدوبامين والابنفرين، وحسيت مع الاتروبين دوبامين او المريض راح على البلوك اللي حنشوفها مثل ما حكينا فتره بعد الظهر، بساعتها بنروح على what we call the transcutaneous pacing or which is يعني it will be given in the afternoon session. هيدي بالنسبه للبراديكارديا. اوكي any question about البراديكارديا؟ قبل ما نروح على excellent. يلا يعني very happy الحمد لله انه عم تفهموا كل شيء و are very happy with your يعني مشاركتكم معنا. طيب كمان حكينا عن الشوكبل والنون شوكبل، في عنا فاذا ركزنا على فوركاست شوكبل نون شوكبل تاكيكارديا وبراديكارديا. حكينا عن الشوكبل وحكينا عن النون شوكبل وحكينا عن البراديكارديا، حكينا والحين هنحكي عن التاكيكارديا. التاكيكارديا اللي هي تكلمت عنها از الاتريال، وتذكروا كثير supraventricular tachycardia, atrial fibrillation, atrial fibrillation, or it might be a atrial tachycardia or which is caused ممكن تكون نتيجة مثل ما حكينا نتيجة الكافيين، ممكن تكون نتيجة الستريس، ممكن يكون any other problem it might lead to tachycardia. مشان هيك كثير مهمة to observe the patient because the patient if he's stable كمان خليه under close observation. If the patient is stable he should be under close observation. Now he might be stable نفس السيناريو he might go be unstable. شو هي signs of instability اللي هي مثل ما حكينا hypotension, decreased level of consciousness وإلى آخره. Now إذا كان عندي signs of instability شو لازم أسوي؟ ساعتها بروح أنا على السynchronized cardioversion. اوكي عندي synchronized cardioversion وبروح على if there is wide QRS less than بروح على adenosine وهون if there is no wide QRS على الفيجال مانر وادينوسين والى اخره if الادينوسين irregular. فاذا just الانتي بروكايناميد والاميودرون والى اخره. فاذا كثير مهم نعرف same line of treatment. وقت بحكي عن براديكارديا unstable bradycardia, adenosine, epinephrine, dopamine والانترفنشن بتروح على transcutaneous patient. tachycardia كمان بروح على الانتي اريزميا ميديكيشن والسynchronized cardio version. non-shockable rhythm مثل ما حكينا CPR بنروح على الCPR وبنروح على الابنفرين والتريتنج ذا كوز. والشوكابل بنروح على ال 5 cycles 2 minutes shock 200 300 360 joules وبنعطي الابنفرين والانتي اريزميا ميديكيشن. دائما we need to treat the. فإذا this is in term of the atrial and ventricular rhythm and how the patient will be. It's very important كمان مثل ما حكينا نشيك دائما على البلس لأن this is a pulse. It's the main reason for the patient to be coded. In both بكل الحالات once the patient he is coded what will be the next step؟ وقت المريض he is coded وبلشنا الكود CPR done والشوك we gave 3 shock the patient he is intubated. He needs to go for لأنه أنا just to secure the airway ما في يضل على طول على الأمبوباجينج. Patient he needs to be intubated and he needs to go to the nearest or to the ICU. فإذا at this point المريض he needs to be intubated. نحطه على مكنة التنفس الاصطناعي or tracheostomy tube حسب 7 7.5 or 8. إذا كان adult pediatric بروح على 4 4.55 حسب العمر وحسب patient he needs to be intubated and he will go for ICU for close observation. المريض after the code he will be after securing the airway ساعتها he will go for ICU. دائما يعني المريض after the code he might go for return of spontaneous circulation which is the ROSC. He might be okay يعني after this one but it's very important just to stabilize the patient and put it to ICU. وقت نفوت بالكود it should take do you know how long time? Maximum up to يعني 30 to or 40 45 minutes code. Everything should be recorded لأنه تذكرنا كمان that everything it needs to be recorded لأنه بدي أعرف إمتى بلش الكود وإمتى انتهى what medication were given والتايمينج it's very important. فإذا هيدي الأشياء اللي نحن المفروض نحن نعرفها عن الاتريال وعن الفنتريكولر وبعد الظهر بنكون مع الايدوفنتريكولر كمان والبلوك بالسيشن الأخيرة. فإذا this is for the atrial and ventricular. Do you have any question بتحبوا تسألونا أي سؤال عن الاتريال والفنتريكولر؟ إذا في أي سؤال I will open the floor for another few minutes. أي سؤال I am ready to answer you now before going for the lunch break. إن شاء الله تكون السيشن واضحة بالنسبة لكم وإن شاء الله أكون توصلت لكم المعلومة اللي that you need to know it. Okay. If there is no question, thank you for your attendance. وإن شاء الله بنشوفكم على الساعة 1. This is a time for salah time and a break. ونشوفكم بخير وسلامة على الساعة 1. Thank you for your attendance. يعطيكم ألف عافية. وبشوفكم إن شاء الله على الساعة 1. حدا بس هون عم يسألني why in the PEA there is no why in PEA there is why PEA no pulse. بالPEA لأنه بيكون في electrical activities but المسل ما عم يعمل reaction على electrical activity we need to stimulate it. يعني في electrical activities يعني يعني but the muscle it's not reacting to it. okay. طيب but اللاين اوف تريتمنت تبع البي اي مثل ما حكينا مشان هيك نحن we'll go for CPR بهيدي الحالة. Thank you and إن شاء الله we will see you at 1 o'clock.
ممكن يجي شيء تضخم البروستات. اول شيء بتبلش بالاشياء خفيفه مثل مثلا تحسين نمط العيش او تغيير نمط العيش، مثلا ما نشرب كثير قبل ما ننام او نظهر في البيت. وممكن كمان نخفف من بعض الاطعمه اللي ممكن تكون مضره للبول مثل مثلا القهوه مثل الكحول، او ممكن بعض الادويه اللي ممكن كمان تاثر على البول. هيدي الاشياء الخفيفه. بعدين نوصل لعلاج الرسم.
في صوت الحين يا شباب ولا ما في؟ Is there a voice you can hear? Okay. So welcome back after the break. Inshallah, this is gonna be like a light session. And yeah, we are gonna proceed. So now we will talk about junctional rhythms, okay? Do you want to proceed or like everybody's here, I hope, okay? Right. What do you mean by junctional rhythm, okay? When we talk about junctional rhythm, we are referring our origin of the pacing to the location between atria and ventricle. This area is called the junction. And of course, this has been described very well in the anatomy session, okay, as I believe. And the main function of the junction is to work as a relay point between the atria and the ventricles. It works as a regulator for excessive atrial impulses, okay? So it filters excessive atrial impulses to regulate ventricular rate, to make it like a regular. And the third function, it works as a secondary pacemaker if SA node is not working. So if the SA node gets sick, our natural pacemaker is not there, the AV node is going to be the secondary pacer. But the atrial pacer, the junctional pacer sometimes become like an irritable pacer. What do you mean by irritable pacer? It fires abnormally within a sinus rhythm, okay? It fires abnormally within a sinus rhythm, and this is where the junctional ectopy happen. So we will cover that part. But let us describe the nature of junctional pacing. In order to understand the nature of the junctional pacing, if you focus at the diagram here, you observe that junction, which is the bundle of His and the AV node together, they are in the middle of atria and ventricles. So they fire retrograde, okay? So they fire retrograde. So they backfire their impulse or stimulation to the atria, while their ventricular electric pacing is going through the normal vendor of the electric impulse, because normally the SA node is up, so the normal vendor, which is the axis or the direction of electric impulse, goes from atria to AV node down to ventricle, so all are in the same direction. So you will see the P wave, the QRS are in the same direction, whether they are positive or negative. Like in lead 2, you will see a positive P wave and a positive QRS. But in case of junctional pacing, what is happening? The nature of the junction in the middle, atria is gonna be paced retrospectively. What does retrospectively or retrograde? It means the direction of electricity is in the opposite direction, so the P wave is gonna appear inverted, okay? Or negative P wave. Now, also, the second thing we need to know about junctional rhythm, okay, that the timing of the occurrence of atrial pacing in correlation to junctional pacing, it might be recorded before the QRS, and in this case, you will see the P wave before the QRS, but it is inverted, okay? But it is inverted. And in all situations, there will be an isoelectric phase between atria, and ventricle. So you will see a fully developed T wave with an isoelectric line, then it is followed by an inverted P wave before the QRS, okay? So this is one form or one picture, okay? Second, you might see a narrow QRS, and we said in the morning that narrow QRS because the pacemaker is a higher pacer, okay? Because the nature of ventricular pacers, you see a wide QRS, but the nature of atrial, junctional, supraventricular, and sinus, the QRSs will always be narrow, okay? So the junctional rhythms are always or almost always associated with narrow QRS, okay? So P wave is inverted, as we agreed, because of the nature of the retrograde pacing. QRS is narrow, but the location of the P wave might be before it is inverted or within. You see a narrow QRS, but there is no P wave before, there is no P wave after, and the P wave might happen after the QRS, but you will see it after the S. Okay, you will see it after the S, and this is how we distinguish between junctional P wave after the S and ST depression. Okay, now how can we do that? If I will take this line here, if you look at this example, okay, I want you to look before the QRS, there is no P wave. You have Q, R, and S, and this is the ST segment. If you see the segment here, if you are following with me, okay, this is the ST segment. Like if there is a P wave here, this should precede and become a straight line, okay, regardless whether there is a P wave here or there isn't a P wave here, okay? Now, if you look here, there is a wave hanging here between the S and the T. So this is a P wave hanging inverted between the S and the T. And then the T wave is happening there. And this is what we call it a junctional P wave after the QRS. And it's very clear in this example, okay? The P wave here is after the S, because here you have the Q, R, S, and this is the ST segment, and then you have the inverted P wave, then the segment continue after the inverted P wave in order to develop the new T wave. Okay, so this is the nature of the junctional rhythm. Okay, the nature of the junctional rhythm, it is an inverted P wave in a narrow QRS, and this inverted P wave can happen before, during, or after the QRS. So whenever you see a narrow QRS, look at the P wave. If the P wave is inverted before or does not exist or inverted after, this is junctional rhythm. Okay, this is junctional rhythm. Clear? So this is the description and the nature of the junctional P wave. This is how we identify a junctional complex. And why do we call it junctional complex? Because this complex in particular has been paced by the junction, okay? By the junction, which is AV node and bundle of His. Right. What do you mean by PJC, premature junctional contraction, or a junctional ectopy? Okay? When we talk about junctional ectopy, it is an early QRS. What does early QRS mean? I want you to look at this rhythm, okay? I want you to look at this rhythm to analyze. Rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. What is the rate? Hello. أديل عادل مريم 110 صح. Okay. Exactly أحمد 110. طيب let us look, is it regular or not? From here to here is equal to here to here is equal to here, but when you come here this QRS comes earlier. And what did we agree before? We said when we have an irregularity we have to look what is happening here. This one is regular, this one is regular, but if you look here, see this complex here. Okay, I want you to look here. This area is shorter than this area, so there is irregularity. Now, okay, keep this in mind. Continue here. There is a شوية delay, irregular, but there is a P wave here. Then we will evaluate the P wave. Here I have a sinus P wave, which is rounded, positive before the QRS, rounded, positive before the QRS, rounded, positive before the QRS. But when it comes here, the P wave is inverted. You can see the inverted P wave here. I am just showing by using the mouse. Continue here, you have sinus P wave, sinus P wave, sinus P wave, sinus P wave, also sinus, and here the P wave is sinus. Okay, so except for this complex, all P waves are sinus, all P waves are almost identical. PR interval is 1, 2, 3, 4. This is 0.16. This is normal PR interval. The QRS is from here to here is like 2, which is 0.08, which means this is a narrow QRS. So rate is 110. Majority or almost all except one complex are sinus. So we call the rhythm sinus tachycardia. Okay, we call the rhythm sinus tachycardia. Do you agree with me? Yes, we agree except for this abnormality. Okay, still did not discuss this abnormality. This complex, which is this QRS, came earlier. Okay, because it came earlier, yani the distance from R to R is narrower, so it is an early conduction. And what causes that early conduction is the born of a junctional P wave. So in this particular complex, in particularly, okay, in specifically, the junction has fired or paced abnormally. This is what we call it, irritability in the junction, which creates a fire or a pacing that conducted a junctional P wave. Of course, a junctional P wave is gonna be followed or preceded by a QRS. So that's why we call this a premature junctional contraction. We call this a premature junctional contraction. So if I want to give a description to this, what I will call it, I will say this is a sinus tachycardia with a premature junctional contraction. It is a single event in this 6-second strip, okay? It's a single event in this 6-second strip. What can cause this junctional premature? Like all PVCs, all PGCs, all PACs are caused by ischemia, enlargement or stretch of wall of the heart, and electrolyte imbalance, okay? And electrolyte imbalance. And it gets treated by usually correction of electrolytes and antiarrhythmic medications. The most common ones are lidocaine infusion or amiodarone infusion, okay? Or amiodarone infusion. And if they are simple and they don't interfere with life, but it has to be seen by a cardiologist, okay? Right. Is it clear, the PJC? So this is how we recognize it. We identify the baseline rhythm, which is sinus tachycardia, and there was an excluded QRS that does not have a sinus P wave. It has a junctional P wave, and that's why we call the rhythm sinus tachycardia with a premature junctional contraction. And here it is a single event in a 6 second. Okay, if I'm gonna monitor the patient, it might have happen much more frequent. Okay. Is this clear? واضح. Is this clear? Do you have any question about it? Excellent. طيب. I want you to identify this rhythm with me. 1, 2, 3, 4, 5, 6, 7. The rate is 70. Okay, so there is no bradycardia. P wave here is sinus. QRS is narrow. P wave here is sinus, QRS is narrow, and here I have an early conduction, okay? Because it's early. If you look between this QRS and the next QRS, you will see only one wave, which is the T wave, because it looks this one. And if you look after this QRS, what you will see? You will see a P wave. And the nature of this P wave, it comes after the QRS, inverted after the ST segment. Okay, so this is a PJC. In the previous rhythm, the P came inverted before the QRS. In this example, the P came inverted after the QRS. So I have a sinus rhythm with a premature junctional conduction. And here you have P wave followed by a QRST, P wave followed by a QRST, and here I have an early conduction, and this early conduction is a narrow QRS followed by a P wave after another PVC, okay? This is another PVC. So in this rhythm, we have a premature junctional complexes, okay? But don't forget to see with the baseline rhythm, because sometimes the baseline rhythm is more dangerous than the junctional premature, okay? Conduction. So the baseline rhythm is sinus rhythm with premature junctional conduction, okay? And it happens alternatively 3 to 1, okay? So 3 to 1. Which means every third is a PJC. This is what we call it junctional trigeminy. This is what we call it junctional trigeminy. Tri means the third one is a PJC. So 2 sinus, if it is 1 sinus, 1 PJC, we call it junctional bigeminy. 2 sinus, 1 PJC, we call it trigeminy. So this is junctional trigeminy. Clear? So these are 2 examples of what we call it premature junctional contraction, PJCs. طيب. The next picture is when the junction become a dominant pacemaker. Okay, when the junction become a dominant pacemaker. In this case, SA node is not functioning and the pacemaker escape to junction. Okay, يعني ال SA node ما شغال. It's diseased, not functioning. There is no sinus rhythm at all. The secondary pacemaker become the junction. لأنه this is the nature of our heart. We have a backup pacer. So the backup of our sinus pacer is our junctional pacer. In this case, the junctional pacer, when it is dominating the pacemaker, it has 3 different classifications based on the rates. Okay, based on the rate. Right. Let us analyze this rhythm. Rate is 1, 2, 3, 4, 5. What is the rate? $50. Okay, so this is between 40 and 60. طيب. Let's look at the P wave. P wave is it regular first? Yes, it is regular, R to R. Second, the P wave is inverted. Inverted before or after? Before. And the main important thing about inverted P wave, it will be preceded by a straightforward segment and a straightforward segment. Okay, before and after. يعني it is hanging. تيجي كذا معلقة على الحبل. تعرف كيف لما تكون شيء منشور على الحبل when you hang something on the rope of a cloth, it is like hanging down. It's dangling there. Okay, it is dangling there on the isoelectric line. There is an isoelectric segment before and after the P wave, whether it is before or after. But this one, a P wave before the QRS. طيب. Second, what is my PR interval? If you calculate with me 1, 2, okay, so 2 times 0.04 is 0.08, and this is sometimes the nature of the junctional PR interval. It gets shorter, okay? It gets shortened. Sorry, معلش for the interruption, okay? This was a top emergency call. Sorry, okay? طيب, let us proceed. So, we said that the PR interval is very short. Why? Because this is not sinus. So the concept of PR interval in junctional does not apply the same rule of sinus. Okay? You will notice that PR interval is shorter than sinus rhythm. Second, the QRS and all the P waves are identical. All the P waves are identical. Okay, they are all the same. Now, we will go to the QRS. The QRS, we measure it from the beginning of the Q, which is here, to the end of the S, which is here, which almost like 0.08, which is normal, okay? Which is normal. So, if you see such a rhythm, would you say bradycardia or normal as a rate? Hello? You can hear? في صوت ولا لا؟ Okay. So this is bradycardia. So by classification, okay, this is bradycardia. By classification, this is bradycardia. So if the patient is symptomatic, in this case, we will apply the bradycardia rules. What are the bradycardia rules? We will check patient pulse. We will check blood pressure, level of consciousness, symptoms of hemodynamic instability, and we can give atropine, we can start epinephrine infusion, and we can hook the patient to transcutaneous pacer اللي هو يعني subcutaneous external pacemaker until the patient is seen by the cardiologist and the situation is fixed. Okay, so this is for the junctional rhythm. How do we distinguish between junctional rhythm and bradycardia? But we don't call it junctional brady. The terminology here is junctional rhythm only. We say junctional rhythm. Everybody understand that. Okay, understand that this is a rate of less than 60, but higher than 40, but it is junctional because the P wave is inverted. Okay. Next is accelerated junctional. What do you mean by accelerated junctional? Okay, let us apply the rules here. 1, 2, 3, 4, 5, 6, 7, 8, 9. What is the rate? 90. ممتاز. Okay, is it regular? It is regular. Yes, it is regular. طيب, is there a P wave? Absent P wave. ممتاز. So I cannot identify a P wave at all. Okay, so in this case, I will ask myself different questions. Okay, what will identify whether this is a ventricular rhythm or a junctional rhythm? If atrial fibrillation, no. Atrial fibrillation is always irregular R to R. This is one. Okay? Atrial fibrillation is irregular R to R. And my question is, how do we distinguish between junctional rhythms and ventricular rhythms in the absence of QRS? In ventricular rhythms, the QRS is wide. In junctional rhythm, the QRS is narrow. أحسنت يا أحمد. Okay? And if the QRS is narrow and I cannot see the P wave, and this is junctional rhythm. Okay? This is junctional rhythm. Okay? So that's why in this rhythm, I have 90. So the rate is between 61 to 100. So it is higher than 60 and below 100. This is junctional rhythm. Okay, this is junctional rhythm. Second, I have no P wave to identify an absentism of no P wave, of the absentism of P wave or there is no P wave, that takes me to think about either a junctional rhythm or ventricular arrhythmia. Okay, so how do I distinguish between them? Narrow QRS makes it junctional. Wide QRS makes it ventricular arrhythmia. In this case, what is the measurement of the QRS? If I go from here to here, okay, so I have around 1.5. okay. طيب, why accelerated? ممتاز. Okay, why accelerated? Because the rate is higher than 60. The rate is higher than 60. But again, why accelerated? Because normally, okay, we don't say junctional narrow QRS. We say junctional. Because when you say junctional, everybody understands the QRS is narrow. But I will answer Ahmed's question. Why accelerated? Because the normal action potential of the junction is between 40 to 60. Okay? Is between 40 to 60. طيب. نرجع ورا. A normal junctional action potential يعني من الله كده. Okay? الجنكشنال ريد بيسر طبيعة 40 to 60. When it gives me a rate higher than 60, this is accelerated. طيب, what can cause acceleration of the junctional rhythm? It's like any pacemaker in the heart is gonna respond to stress, hypoxia, hypotension is gonna be stimulated by sympathetic nervous system and the catecholamines, which is mainly the epinephrine, okay? So when there is a sympathetic stimulation for the junctional pacer, it is gonna increase the rate to compensate for decrease in contractility, okay? And in order to compensate for hemodynamic, okay, needs. So it will become accelerated. طيب. In this case, patient is going to be evaluated for hemodynamic stability. طيب. Majority of patients with accelerated junctional rhythm, those who have decrease in cardiac output, okay, they need something to strengthen the heart contractility. What is the major medication that strengthens the heart? إيش أحسن علاج يقوي القلب في حالة إنه أنا عندي arrhythmia and I need to improve the contractility of the heart? لا مو الديجوكسين. الديجوكسين يستخدمه في الهارت فيلر. ايوه ابنفرين. اوكي ابنفرين تعطي الديجوكسين it will take time. بعدين الديجوكسين is gonna slow the heart. انا I don't want to slow the heart. اوكي انا اصلا ما عندي اس اي نود. اوكي انا عندي secondary pacemaker فحتعطي ديجوكسين this is gonna slow the heart. I don't want to slow the heart. And I want to increase the rate and I want to increase the contractility. But the drug of choice here is epinephrine. And we prefer to use pacemakers. Dopamine is okay, but dopamine does not increase the contractility of the heart. It only increases heart rate and cause vasoconstriction. Dopamine is not an inotrope. Dopamine is a vasopressor and a chronotrope. Okay? لحتى نكون واضحين. الدوبامين does not increase contractility. الدوبامين increase heart rate or cause vasoconstriction. The drug that can cause vasoconstriction, contractility, and heart rate is epinephrine. Okay? The drug of choice here is epinephrine and use pacing. Okay? Use external pacing. And the patient might require to be placed on a pacemaker as a permanent solution. Okay? ممتاز. ننتقل next junctional tachy. Okay? What do you mean by junctional tachycardia? Let us apply. احنا سميناهم الكبسة rules. اوكي. we eat ECG by hand. صح ولا لا؟ طيب نعتبر هذا الريتم صحن كبسة ونشتغل عليه. يلا put your hand on the rhythm. 1 2 3 4 5 6 7 8 9 10 11 12. The rate is 120. ممتاز. مو 12. 120. اوكي. طيب is it regular? Yes, it is regular. And there is no abnormality as irregularity in the middle. Okay, let us look for the P wave. Before the QRS, do you see anything? I see nothing as a P wave before the QRS. طيب اللي يقول absent, I want you to analyze this QRS. And what I'm gonna do, I will just escape. Okay. And I will just augment this. بس بخلي ال ECG أكبر. صارت أكبر أوضح. أيوة. أيوة. لأنه الجنكشنال rhythms when the P wave is after, it's one of the most confusing rhythms. If you look here, you have the T wave followed by the QRS. This one is the Q, the R, and you have the S. So I have a complete QRS complex. The expectation here, I should have a straight line, which is the ST segment. And this is the T wave. But I have something hanging here. This is not ST depression. If there is ST depression, the S is not going to go up here. It will go here. Okay? So the S is back to normal position. And then another wave is hanging here. This is the P wave after the QRS. Okay? Always لما تشوف ال ST segment هنا جالس ما في ST depression. Okay? ما في ST depression. هنا you have an S followed by and if you want to compare this to this is an ST depression but not significant. It's only like a small square. Okay, it's only a small square. It's not a significant thing. But here you have the P wave after the QRS. So the T wave is there, the QRS is there, and the QRS size is from here to here. You have 1, 2. 1, 2, okay, and a half. طيب 2.5 times 0.04 is 0.10. And when you say 0.10, يعني 0.10, this is a normal QRS or a narrow QRS. So I have a ventricular rate of 120. This is tachycardia. I have a narrow QRS, and I have a P wave after each QRS inverted. So this is junctional tachycardia, okay? This is junctional tachycardia, okay? Clear how we identify junctional tachycardia? Okay, fine. Junctional tachycardia, when we treat it, we apply all the rules of tachycardia. Yani, we might try to control the rate, and we control the rate by beta blockers, calcium channel blockers. This is one. We might use pacemaker, okay? But we will never use synchronized cardioversion, okay? خلها في بالك. Keep it in your mind. Junctional tachycardia there is no synchronized cardioversion. Why? ليش ما حنعمل synchronized cardioversion؟ يعني ليش ما في electric therapy هنا؟ ليش ما في defibrillation, synchronized defibrillation؟ Simply because the junction replacing SA node. So there is a very high risk that when you defibrillate, يعني by using synchronized cardioversion to this rhythm, you erase عادل is asking. طب عادل خلينا أكمل فكرة الكارديوفيرجن بعدين نرجع لسؤالك. سؤالك جدا قيم. أوكي؟ جدا ممتاز. احنا قلنا we have said اوكي حكينا انه احنا ما حنستخدم كارديوفيرجن في الجنكشنال تاكيكارديا بسبب الخوف انه انت لما تعمل كارديوفيرجن انت بتلغي البيس ميكر. اوكي انت you erase the electricity in the heart to give the chance to SA node to pick up to become the dominant pacemaker. In junctional rhythms, the problem in junctional tachycardia in particular, انت لما تعمل كارديوفيرجن when you cardiovert الخوف انه انت تلغي البيس ميكر والاس اي نود اصلا مو شغاله فالمريض حيروح باسيستولي. اوكي باسيستولي يعني يقولوا بالعربي جيت تكحلها ايش عملت فيها؟ يقول لك جاي كحلها عماها. فدونت كارديوفيرت تاكيكارديا junctional tachycardia. الجنكشنال تاكيكارديا the best therapy شيء نقول له override pacing يعني انك تحط بيس ميكر اوكي in order to override الجنكشن حتى ترجع المريض للنورمال ساينس ريذم. اوكي طيب نرجع لسؤال الاخ عادل. اوكي the question is what is the difference between accelerated junctional tachycardia and junctional tachycardia and accelerated tachycardia junctional rhythm. صح accelerated junctional rhythm and junctional tachycardia is the rate. هذا الفرق الوحيد. okay is the rate. in accelerated junctional rhythms the rate is less than 100. okay in junctional tachycardia the rate is 101. it can go up to 180. هذا واحد. second الجنكشنال tachycardia is more associated with instability of hemodynamics. والسبب the cause of instability يعني hemodynamic instability in junctional tachycardia is more common because number one is synchronization between atrial filling and ventricular filling is a problem. يعني ventricular filling will decrease. okay هذا سبب. اثنين التاكيكارديا will shorten the diastolic time. okay the diastolic time is going to be shorter and when you shorten the diastolic time the filling of the ventricle is gonna decrease. So when you decrease the filling of the ventricle the contractility and the stroke volume is going to decrease, cardiac output will decrease, and it will be associated with more symptoms. Okay, will be associated with more symptoms. That's why we try to decrease the heart rate in order for the filling of the heart. Second, we will try to use a pacemaker. Okay, in order to control the symptoms. واضح؟ طبعا الجنكشنال can be caused by digoxin intoxication can be caused by septal infarct. okay can be caused by atrial ischemia. I mean okay damage to SA node. It will lead to escape of the pacemaker down to the junction. okay so the most important thing about junctional rhythms is to identify the junctional rhythm by recognizing the by recognizing the cause: myocardial ischemia, congestive heart failure, or digitalis toxicity. Okay, because in majority of the time it could be caused by either an acute or a chronic cause. Okay, so we need to identify the cause, and it's very important to establish therapy as soon as possible. Okay, طيب بالنسبة للتوبيك على الجنكشن. Okay, it's almost like done. Just to recap. Okay, just to recap يعني حتى بس أعيد الكونسبت مرة ثانية. الجنكشنال rhythm, it's paced by the junction, that's why we call it junctional. فإحنا سميناه junctional لأنه الناتشر أو الأوريجين of pacer جاي من الAV node bundle of His اللي إحنا نسميها الجنكشن. هذه المنطقة في الوسط. that's why the nature of firing, it fires retrograde to the atria, which gives me an inverted P wave. It fires and I told you that there is an asynchrony between atria and ventricle as filling when the atrial contraction happen. Okay, during or before QRS. Okay, during or after QRS. And you need to remember one thing, that ECG, okay, when you see the wave, this is the electric picture. Okay, this is the electric picture. يعني هي الصورة الكهربائية. Synchronization with timing between electric impulse and filling of the chamber, there are some delays. Okay, there are some delays. So you cannot identify exactly whether there is a coordination or not, but definitely the filling of the ventricle is affected. Okay, is affected when there is an asynchronization between atria and ventricle. Okay, between atria and ventricle. This is one. Second, we need to know that ventricular filling, okay, ventricular filling, it does not depend on much on the atrial contraction. Okay, the ventricular filling happen under the effect of the relaxation of the ventricle. يعني الفنتريكلز تتعبى دم. اوكي، بسبب السحب اللي هو السلبي اللي تسببه امتداد الفنتريكلز. بس اكيد الاتريا it participate in around 20 to 25% of ventricular filling. فلما يكون في asynchronization ما بين الاتريا والفنتريكل in the filling, ventricular filling is going to be affected, okay, by 20% تقريبا. okay, this might affect the contractility. لأنه إحنا عندنا قانون اسمه فرانك ستارلينج law. It says the more you fill the ventricle, the more you stretch the muscle, then the contractility اللي هي الريباوند نسميها. اوكي، ردة فعل المصل لما تعبيها انت دم اكثر حيكون الانقباض اقوى. So when you fill more the ventricle, the filling, the stretch اللي هو البريلود والstretchability of the wall of the ventricle is going to be stronger. فthe rebound, the contractility is going to be stronger. If there is asynchronization in the filling between atria and ventricle, okay, but that's why in junctional rhythm, accelerated junctional rhythm, junctional tachycardia, you might see symptoms of hemodynamic instability related to decrease in atrial participation in ventricular filling, and in tachycardia, decrease in the diastolic time. The diastolic time is short. For shortening of the diastolic time, decrease the filling of the ventricle, and also might cause decrease in the stroke volume, which will lead to decrease in the filling of the aorta and the arteries. That is going to decrease cardiac output. Okay, so that's why we focus on increase the heart rate, make sure that the contractility is happening. That's why it is advisable to use cardiac pacemaker in junctional arrhythmias. Okay. طيب. Focus to distinguish between premature atrial contraction and premature junctional contraction, because in the premature atrial contraction and the premature junctional contraction, in both you have an early QRS. In both the QRS is narrow, but in the atrial اللي هي نسميها ال PAC, the P wave is fused or interfere with the T wave, and it is positive energy. But in junctional, it comes as inverted, and it might be a PJC with a P wave within or after the QRS, like what appears here. Here, this is a PJC with a P wave after the QRS, and here it is a PJC with a P wave before the QRS. But both are treated the same way, okay? And also the recurrency of PJC might affect hemodynamics. يعني when it comes in more recurrency, like here. Here we have junctional trigeminy, okay? It might be junctional bigeminy. Always PJC, PAC, PVC affect the filling of the ventricle and might lead to decreased cardiac output as well. So you might see symptoms in your patient. Okay? So in junctional rhythms, we focus a lot on using pacemaker. Okay? طيب, that's it for the junctional part. If you have any more questions, you are welcome. If not, and I'm gonna stop the slide share and open the door for questions and give the chance for the next presenter, okay, to start the share. And if you would like to start just before the time, because I think I am finishing 5 minutes before my time, okay? So you can invest this time for questions or by starting the last presentation. Okay, we are good so far. Thank you very much. There is one other presentation, okay, by Dr. Antonio, okay? He's gonna follow that. باقي محاضرة, okay? باقي محاضرة. Thank you. No, this is not too long. You should enjoy it. Thank you. Yes, the next presentation will be the last presentation. Okay, thank you. Dr. Antoine, the floor is yours. Thank you.
Yes, thank you. I will share my slides. Can you see the slides? Okay, great. So the last topic of today is about heart block and treatment. We already talked about heart conduction anatomy, then we talked about arrhythmias, atrial and ventricular arrhythmias, and we talked about junctional arrhythmias. So we mainly focused on tachycardia, tachycardic urgencies. Now we'll start talking about heart block. So we'll focus more on bradycardia. So first, I will share the slide again. We show it in the first presentation. It's just a summary for the heart conduction system. So we have the SA node, as we said, it's the main heart pacemaker in normal conditions. It will generate electric activity that will propagate to the right atrium and simultaneously to the left atrium. So this will allow for atrial contraction. So blood will be pumped from the atrium to the ventricle. Then we have the AV node. So the AV node will receive the electrical signal from the SA node, and it will propagate the signal towards the ventricles, towards the His bundles, then towards the right bundle and left bundle, then toward the left, towards the Purkinje fibers. And by this process, this electrical activity process, we will have ventricular contraction. So blood will be pumped into the aorta and pulmonary artery and will be pumped to the systemic circulation. So this is like a summary of what we said this morning. Now we'll start talking about pathologies affecting this pathway. So first, we will talk about the most common pathology that we see is the first-degree heart block. So this is in the picture here, you see the AV node. So here, all the impulses that will reach the AV node from the SA node will be able to pass through the ventricle. But the difference here is that the electrical signal will move in a slower pace. So all will pass, but it will be at a slower pace. So we will have a delay of impulses that will reach the ventricle, and this form is the least severe. So it's not severe at all, and we can just observe the patient without any treatment. It will not cause any symptom or major symptoms. So here is the ECG. As we saw in previous lectures, we have the P wave, which is the atrial contraction, and the PR interval, which represents the propagation of electrical activity from the SA node through the AV node. So normally the PR segment is 0.16 seconds or 160 milliseconds, or 4 small squares, because each small square is 0.04 seconds or 40 milliseconds. So normally it's 160 milliseconds, the PR segment. But in first-degree heart block, what will happen is that the PR segment will be prolonged. So instead of having a PR segment of just 0.16 seconds, the PR interval will be above 0.2 seconds. So this is how we diagnose a first-degree heart block. So as you can see here on the image, the PR segment from the beginning of the P wave to the beginning of the QRS complex. So we have 1, 2, 3, 4, 5, 6. So we have 6 small squares, which means that the PR interval here is around 6 times 40, which is about 240 milliseconds. So it's above 200. So we have a first-degree AV block, and this means that there is delay in the conduction through the AV node. So we diagnose it by just looking on the ECG. What can cause first-degree heart block? So usually we can see it in a lot of young individuals due to increased vagal tone, because as we said before, the innervation, the parasympathetic innervation of the AV node and SA node is through the parasympathetic fibers by the vagal nerve. The vagal nerve, which is a cranial nerve number 10. So it will cause decrease and it will slow the electrical conduction. So increased vagal tone, it's very common, especially in athletes and young individuals during sleep. If they do a Holter tracing or telemetry tracing, we most often see periods of first-degree heart block. It's very safe and it doesn't cause any other abnormalities. So as you said, athletic training, because they used to have more vagal tone as compared to non-athletic individuals, inferior myocardial infarction, because when we have an inferior myocardial infarction, it's the right coronary artery that's affected. The right coronary artery would give blood supply to the inferior wall of the heart. So when this artery is blocked, we said that the branch that reaches the AV node comes from the right coronary artery. So when there is no blood supply coming to this artery, we can have problems in the AV node and the SA node. Mitral valve surgery, because the mitral valve location is close to the AV node. So when we do surgery to the valve, there's a risk of developing edema in the post-operative state. So when we have edema around the AV node, there is a risk also of causing pathologies due to edema. Myocarditis as well will cause areas of fibrosis and edema are surrounding the AV node. Lyme disease, it's a bacterial infection. We'll see it later in this presentation. It can cause AV block. It's very common in the United States. We don't have it here in our regions. Electrolyte disturbances like hyperkalemia, so potassium level, especially when it goes above 6, especially in chronic kidney disease patients and dialysis patients, is a high risk of developing any type of AV block. Medications like beta blockers, so medications that slow down the heart rate and slow down the AV node, beta blockers, calcium channel blockers, digoxin, and amiodarone, all will cause slowing of the AV node. And as we said, it can be normal variant in a lot of individuals, mainly due to increase in vagal tone. So here is an example of a patient. As you can see on the ECG, always look on the long strip. So if you look down on the lead 2, the lead that is on the bottom of this ECG, it's the long strip lead. So you can see clearly a long strip. So we have a lot of complexes here. As you can see, we have P wave followed by QRS, followed by T, then P wave followed by QRS, followed by T, and it's repetitive. So it's irregular sinus rhythm. So when we have P followed by QRS followed by T and it's regular, so we say it's a sinus rhythm. But here, as you can see, if you count the PR interval, the PR interval here is around 260 milliseconds. So it's above 200 milliseconds. So here we have a prolongation of the PR interval. So it's clearly a first-degree heart block. This condition is very benign, as we said. No pacemaker is needed. No additional therapies are needed here. But sometimes, can someone tell me what is the problem here? If you look, if you look on the PR segment, what do you think is the problem here exactly? Okay, so if you look closely, the PR segment here is very prolonged. So it's about 300 milliseconds. So if we count the squares, 1, 2, 3, 4, 5, 6, 7, 8. So here it's about 320 milliseconds. So in that case, we can say we have a marked first-degree AV block. So here, in this case, usually we said that in first-degree AV block, there is no need to put a pacemaker or to treat. But sometimes when the PR segment is very prolonged, and in case of symptoms, for example, if this patient presents with syncope or loss of consciousness that's not explained by any other condition, in that case, we can tell the patient that a pacemaker might help him. But in the guidelines, it's not a class 1 recommendation to put a pacemaker to first-degree heart block unless there is a very significant symptom not explained by any other pathology, and when the PR segment is very prolonged above 300 milliseconds. In that case, we just can think of putting a pacemaker, but in all other cases of first-degree heart block, there is no need to place a pacemaker. So, as we said, no treatment is required. If the patient is already on beta blocker, so on heart-lowering medications, heart rate-lowering medications, we can reduce the dose. We do not stop the medication, we just reduce the dose. And no pacemaker is needed unless the PR is above 300 milliseconds and there is syncope, and there is no other explanation for the syncope. So we do a CT brain, we do all other investigations. If we don't find anything, we can attribute to the syncope to the very prolonged first-degree heart block. And in that case, only we can put a pacemaker. Now we move to the second degree heart block, which we call also the Mobitz type 1 heart block, or we can call it Wenckebach block, because the physician that discovered this type of heart block is Dr. Wenckebach. He lived between the 19th and the 20th century, so he discovered this condition. So here, the problem is that the electrical signal gets slower and slower between beats, and over time your heart drops a beat, and then the process repeats. So here there's conduction through the AV node, there's slowing as well, but the problem is more significant than type 1 because there's a beat that will not conduct. So there will be a blockage at the level of AV node, not just a slowing, there will be a blockage. And if you look closely on the ECG that is below, you can see that there is increase in the PR segment. So we have PR here, PR segment, PR segment, PR segment that is increasing over time, and then there will be a P wave here that's not followed by a QRS complex. So in that case, we call that we have a dropped P wave, a dropped beat. And this is very typical for Mobitz 1 second degree heart block. So the PR is prolonged from beat to beats. We can see that the PR segment is getting bigger, it's getting bigger progressively, and then you will have a P wave that is not conducted. So there's no QRS after it, and you will see a pause, and after the pause, you will have the system will restart, and there will be a new P wave. So it's very typical for Mobitz 1 second degree heart block. So if you look closely to the P interval, for example, the interval between this P wave and this P wave, it's the same between this P wave and this P wave, because here the problem is not at the level of the P waves or the atria or the SA nodes. The SA node will generate this P wave. The problem is at the level of AV node. So the PR segment will be affected, but the distance between P and P and P and P is the same. So there is no problem at the level of the SA node. Okay. So as we said, Mobitz 1, also known as Wenckebach pathology, results from temporary conduction block. So here, the impulses will suddenly block and there will be no more passage of electrical activity. Unlike the first degree heart block, which will allow the propagation of all signals, but they will be slower. Here, they will be slower, and then there will be ones that will not pass. So AV nodal cell and Mobitz 1 tend to gradually tire or fatigue over time. So it's a disease that we see more frequently in the elderly population in the old age, leading to a progressive decline in their ability to conduct electrical impulses. So this will differentiate from the condition where the His fibers or the Purkinje system fails, because when the His or the Purkinje system fails, here we don't think of a disease caused by age. We should rule out ischemia, but in the case of Mobitz 1, we need it's not a severe condition. We usually attribute it to cell fatigue and to AV nodal fatigue or to age. So the causes of the Wenckebach phenomenon. So Wenckebach, we said it's the second degree heart block, Mobitz 1. As the same as AV block type 1. So we have the medications like beta blockers, calcium channel blockers, digoxin, amiodarone, increased vagal tone like we see in athletes, inferior myocardial infarction, because we said inferior myocardial infarction is caused by obstruction of the right coronary artery, which give also blood supply to the AV node, myocarditis due to formation of fibrosis at the level of AV node, and following cardiac surgery like mitral valve repair, which will induce areas of edema around the AV node. So all these are causes. We can see that a lot of these causes are shared with type 1 AV block. So this is an example of a patient. presenting for this doctor, and he did an ECG, and they found this. And if you look, we said that that always it's better to look at the long strip lead, so the lead that is below. You can see that we have here the P wave, and this is the PR segment. You can see that the PR segment is getting bigger from complex to complex, and here it's at its maximum duration, and then there's a P wave, and we don't have a QRS after it. So here there's a drop beat. So this is exactly Mobitz 1 second degree heart block. So progressive increase in the PR segment. Then we have a P wave that is dropped without a QRS. So it's Mobitz 1. And you can see that it's a group beating. So here we have 1, 2, 3, 4, 5 P waves with 4 QRS complexes. So we can say here it's a 5-to-4 conduction ratio. So for every 5 P waves, we have just 4 QRS. So it's a 5-to-4 conduction in that case. And it will restart again on the next interval. So P wave, PR gets bigger over time. Then we have a drop P wave without a QRS after it, and it's the same 5-to-4, 5 P wave to 4 QRS. So we call this a group beating because the cycle is repeating itself from group to group. Are you hearing me well? Okay, great. So now we continue. So it's we said that Mobitz 1 is also benign. It's not a dangerous condition. It's harmless, like type 1 AV block, and it does not need a medical intervention or treatment in most of the cases. Just for patients that have very typical symptoms like bradycardia or syncope, sometimes we can put a pacemaker, like we said in the case of type 1 heart block. So it's very rare to put a pacemaker for these patients. Now we move to the Mobitz 2. So here we have also it's a second degree, but it's a Mobitz 2 disease. So it's more aggressive type of AV block, and this was discovered by Dr. John Hay. It was discovered like 100 years ago. So he called it Mobitz 2 second degree heart block. If we look back at this figure that we saw it before, we have the SA node, which is here. We have the AV node, which is just below it, and we have the His bundle. So here, in case of Mobitz 2 block, the problem is below the AV node. So it's either in the His or below in the bundle branches or in the Purkinje fiber. So we call this an infrahisian block because it's below the AV node. So it's an infrahisian block. And here it becomes dangerous because these type of blocks can cause a lot of symptoms like syncope or cardiac arrest or sudden death. So here it's a more severe condition because the blockage is below the AV node. It's not like the Mobitz 1 and the first degree AV block. It's not just inside the AV node. Here it's below it. So the Mobitz 2 AV block, so if you look at the ECG tracing, here we don't have a prolongation of the PR segment. We can have just a normal PR segment, as you can see here, but then suddenly there will be a dropped P wave, so a P wave without a QRS complex. I don't know if you hear that sound, but it's outside of my house, so I don't know. I'm very sorry for that. Okay, so as we said, there's a PR segment that is not increasing in duration, but here, like in case of Mobitz 1, we have a P wave that is not conducting. So here there is no QRS after it. There's just a dropped P. Okay. So normal, 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 then P wave without a QRS. So there is a pause after it, then the system will restart with a new P wave followed by a QRS followed by a T wave. So the difference between this and Mobitz 1 is there is no without progressive prolongation of the PR interval. In case of Mobitz 1, we said we have a progressive progressive prolongation of the PR segment. Someone is Ahmed is asking me why name Mobitz and why the drop happens. So the drop happens because we said that the cells will age and will have a fatigue, like a fatigue inside the cells. So there comes a point where these cells will not be able to conduct the electrical signal that is propagating from the SA node. And that's why we can have a drop. So it means that the electrical activity originating from the SA node cannot continue to propagate to the bundle branches and to the Purkinje fibers. So here is another slide about the same topic. So we said the PP interval is the same because the problem is not at the level of the SA node. The SA node will generate the P wave and the atrial contraction. So the P's are coming as they should. But the problem is the P wave that is not conducting, meaning that there is a dropped QRS segment. Can you hear me? Ahmad is saying that there is no voice. Okay, great. Okay. So how to distinguish Mobitz 1 from Mobitz 2? So Mobitz 1 is typically associated with functional suppression of AV conduction, often caused by factors like medication or temporary ischemia that can be reversed. So Mobitz 1 is not dangerous, but Mobitz 2 is more often due to structural damage. So we will have structural damage due to heart conduction system, and this structural damage may be linked to conditions such as myocardial infarction. So we'll have loss of blood supply reaching the nodes or the His bundles or the bundle branches, or fibrosis, like I said, the case of myocarditis or necrosis, which are not easily reversible. So in case of Mobitz 2, most of the time the condition is not reversible, but Mobitz 1, most of the cases it's reversible, and there is no need to put a pacemaker. But in case of Mobitz 2, most of the time, because the condition are related to blood supply or to fibrosis, these things are not reversible, even if we treat the blockage in the blood vessels. Most of the time, the condition will not reverse, and in these cases, we have to put pacemakers. So not all Mobitz 2 are the same. We can have difference in Mobitz 2. So if we can see here in the first diagram, the QRS here is narrow. You can see that the QRS is about 0.8 seconds. So we said that QRS less than 0.12 seconds. We saw it in the previous presentation. It's considered a narrow QRS. So the problem here, it's at the level of the His. But when we go down the system and the blockage is lower, so it's infrahisian, you can see that the QRS complex is becoming wider. So the QRS complex here is above 0.12 seconds or above 120 milliseconds. So not all Mobitz 2 second degree heart block are the same. There's conditions that are more dangerous than others. So when we have widening of the QRS segment, not just blocked P wave, but also widening of the QRS segment, in that case, it's called infrahisian block and is more dangerous as compared to Mobitz 2 with a narrow QRS. And around 75% of cases, the conduction is with a wide complex, so it's a dangerous complex in 75%, and just 25% of cases, you can see that the blockage is at the level of the His, and it's a more benign condition. So causes of MOBITS 2, we said here we should have structural heart disease, so anterior myocardial infarction, like due to septal infarction, because the septal branches from the left anterior descending artery are the blood vessels that will supply the bundle branches and the septal area, because the bundle branches will pass through the septal area. Other conditions like idiopathic fibrosis, like a disease called Lenège-Lev disease, which is disease discovered by a French physician, and cardiac surgery because of the edema that we see in post-operative states, and inflammatory conditions like myocarditis, Lyme disease, we will see them and later in this presentation. Autoimmune disease like systemic lupus, erythematosus, which is an autoimmune disease, or systemic sclerosis. Infiltrative disease, most commonly amyloid, sarcoidosis, and hemochromatosis. Hyperkalemia, as well, as we said, can cause any type of heart block. And drugs like beta blockers, calcium channel blockers, digoxin, and amiodarone can cause it. So now we will start discussing these diseases, each one on its own. So we have this rare disease, which is called Lenège disease. It's an idiopathic fibrosis of the conduction system. So the conducting cells will be replaced by fibrosis. And as you know, fibrosis cannot conduct electricity. And this disease is also associated with aging and the elderly, but we can have also familiar transmission. So it can be also genetically transmitted between generations. And the treatment in that case, because we said here fibrosis is irreversible, so we are obliged here to place a pacemaker in order to restore the normal heart activity. So fibrosis is irreversible, so here pacemaker is an absolute indication, and it's a class 1 indication in order to treat this condition and prevent syncope, cardiac arrest, or sudden cardiac death. Another rare disease in our region, which is Lyme disease. So Lyme disease is transmitted by this vector. It's found in the United States. This vector contains a bacteria, which is a bug called Borrelia, is a bacteria. This bacteria can affect multiple organs in the body, can affect the brain, can affect the joints, but it can also affect the heart, especially the conduction system. So 1 to 2 months after the bug bite, the patient can start developing symptoms. So these symptoms can be due to high degree atrioventricular block, so MOBITS 2 or more advanced heart block. It occurs of 80 to 90% of Lyme carditis. So when the bacteria reaches the heart, so in 80 to 90% of cases, it will progress to develop a high degree AV block. So here it's debatable to put a pacemaker or not in that case, because this disease has a treatment. So like any bacteria, we can give antibiotics. So here we can wait on the pacemaker placement because we think it's a reversible disease. So antibiotics might reverse it and might reverse the development of AV block. And the diagnosis of this disease is by serology. So we can ask for a blood test that will dose the antibodies circulating in the blood, and it can give us a positive or a negative results. If we get a positive IgM results, it means that we have an active infection. If we get a positive IgG results, so it means here that we have an old infection, because IgG means that we have immunity against the pathogen. So we should look for IgM in order to start giving our antibiotics. And in case of development of AV block, as we said, so it depends. If it's a first degree heart block, here we can give per-os medication. So there is no need to give intravenous medications. The first line is doxycycline 100 milligram per-os twice daily, and we give it for 14 to 21 days, so 2 to 3 weeks of antibiotics. But in case of development of second or third degree heart block, in that case, we should give intravenous antibiotics, and we should give higher doses like ceftriaxone, which is a third generation cephalosporin antibiotic, which is given once daily and for a duration of 10 to 14 days. So we give 10 to 14 days of intravenous antibiotics, so the patient should be hospitalized. And then after 2 weeks, we can switch him to oral antibiotics. So we don't put a pacemaker directly. We should try antibiotics first to see if it will reverse the AV block. Another disease which is common mainly in women, which is systemic lupus erythematosus. This disease can also affect pregnant women. And it's an autoimmune disease, so we have formation of antibodies in the blood that will attack various organs. These antibodies can go inside the placenta, here, as you can see in the picture, and they can reach the baby or the fetus inside the placenta. So these antibodies, as we said, can affect multiple organs, including the fetus heart. So they can bind to cardiomyocytes in the fetus, which will affect the electrical conduction and will induce cell death. So inducing cell death is like causing fibrosis. And when the antibodies bind to these cells, we have a cascade of inflammation. We'll have macrophage activation. We'll have release of pro-inflammatory or fibrotic mediators, and this will end up by causing tissue damage and fibrosis. And this will cause blockage in the electrical conducting system and will lead to various degree of heart block. So here as well is we have to aim to treat this condition, and in most of cases, the baby will require a pacemaker placement in case of SLE, SLE in fetuses. And the antibody that is responsible for this is the anti-RO antibodies, which are found in the mother and in the baby. Another rare condition, but we see it most often, is the sarcoidosis condition. Sarcoidosis is a condition that can affect also different organs, can affect the lungs, but it can cause deposition inside the cardiomyocytes of the heart. You can see here on this MRI, it's an MRI view. It's a case report published in journal. You can see that if you follow the white arrow, you can see the position of sarcoid cell in the heart, in the conduction system of the heart. So we'll have blockages, fibrosis, and this will cause also high degree AV block. Another rare condition as well is hemochromatosis. Hemochromatosis is characterized by accumulation of iron in different organs. So we have increase in absorption of iron from the GI tract. So we have a high level of iron and ferritin and transferrin saturation. So when this occurs, iron will deposit in the liver, in the pancreas. So when iron deposits in the pancreas, it will induce pancreatitis or diabetes. And it can also deposit in the heart and can affect the heart conduction system and can cause AV block. So all of these conditions can cause high degree AV block, like Mobitz 2 or like third degree heart block. But Mobitz 2 is associated most of the time with hemodynamic compromise because it can cause severe bradycardia and it can progress to cause third degree heart block. So when we say hemodynamic compromise, we say that the patient will be hypotensive, will have decreased mental status, will have syncope, so the patient will lose consciousness without any explanation. And if the patient is left untreated with this condition, the patient has a risk of 35% per year to develop asystole at rest. So he can have cardiac arrest at any moment, 35% per year, which is a significant number. And this type of block requires an immediate hospital admission to the cardiac care unit and continuous monitoring. And we need to place, it's an absolute indication to put a pacing in cases of Mobitz 2 heart block. We should not wait here on the patient. We should directly place a pacemaker in order to restart the normal heart conduction. So here is an example of MOBITS 2. So you can see that the PR segment is not prolonged, but we have a P wave that is not conducting. So this P wave should have a QRS just after it, but in cases of MOBITS 2, there is absence of this QRS. And when you see this, it's an absolute indication to admit the patient to the hospital and to put a pacemaker. And you can see here the heart rate is low, so heart rate is less than 50 beats per minute. So the patient is bradycardia. When the heart rate drops, we'll have decrease in cardiac output, we'll have decreased organ perfusion, we'll have hypotension, we'll have decreased mental status. So the patient will become unstable due to hypotension and decreased mental status. And a pacemaker here will restore the normal heart rate. Moving now to the third degree heart block, which is the more severe type of AV conduction abnormalities. And you can see on this ECG that the P waves here, the P wave here, the P waves are not related to the QRS. You see here the PR segment is different than this PR segment. Each P wave, the atria is beating on its own, and the ventricle is beating on its own. So we have a complete dyssynchrony here. The atria is alone and the ventricle is alone. Here is the most dangerous situation because it can cause very low heart rates, like heart rates of 20 beats per minute or 30 beats per minute. And here is an emergency to put a pacemaker. Okay, so there is no AV conduction, no electrical activity coming from the SA node is able to pass through the ventricle. So unlike other conditions like MOBITS 2, MOBITS 1, or first degree heart block, here we have absolute blockage. So there is no passage at all. And here, how the patient stays alive, because as we saw in the previous discussion about junction rhythm, here the AV node or below the AV node will start producing electrical activity at slow rate. So we'll have a junctional escape rhythm. So the rate here will be low. So when you have junctional escape rhythm, we have a rate that's about 40 or maybe lower in some cases. And this can lead to sudden cardiac death if not treated or if it stays for a long period of time untreated. So sometimes MOBITS 1 and MOBITS 2 can lead to third degree heart block. MOBITS 1 rarely, but MOBITS 2, if left untreated, can lead to this type. Because we said that MOBITS 2, it's caused by structural heart disease, so it's not reversible in most cases. And if we leave it like this, it will progress. But MOBITS 1 is more responsive to medications and usually have favorable prognosis. So causes of complete heart block, like MOBITS 1 and MOBITS 2, most common cause is myocardial infarction. So there is alteration in blood supply, so no more blood is reaching the area of cardiac conduction. So in that case, we have complete blockage, medications, beta blockers most commonly, and we can have the disease we discussed before, Laneige disease, which is a fibrotic disease affecting the electrical conduction. Okay. So urgent hospital admission is necessary for these patients, and continuous monitoring and pacing should be placed. If we don't have a doctor that can place it, we can put a temporary pacing. So temporary pacing, we go by the femoral vein, and we then move up the pacemaker electrode in order to reach the right ventricle, and it will start pacing. But we can't keep this for long. We should put a permanent pacing, which is a subcutaneous pacemaker, which we put usually on the left side of the chest. So we can't leave we can't stay on the temporary pacing for long, just 48 hours, and then we need to bring an electrophysiologist in order to put the permanent pacemaker for long-term management. And in case of the pacemaker is not available, or the doctor that puts the pacemaker is not available, we can start by trying to give medications, which are intravenous medications. Usually, high degree AV block is not responsive to atropine. Atropine is usually given at 1 milligram doses, but usually high degree AV block is not responsive to atropine because atropine acts on the AV node, but high degree AV block is below the AV node, so it will not respond. We can try isoprenaline, 1 to 10 microgram per minute, and we can also try adrenaline or temporary pacing, awaiting the placement of the permanent pacemaker. Now we finished with heart blocks. So now we have other types of blockages in this conducting system. As you can see here, we have the SA node, then we have the AV nodes, then we have the HIS here, and then we have the right bundle branch, and we have the left bundle branch. The left bundle branch is divided in left anterior fascicle, which is here, and it's divided in left posterior fascicle, which is here. While the right bundle branch is just a single structure, so there is no there is a single structure in the right bundle, but the left bundle is divided in left anterior and left posterior fascicle. How can we differentiate between these conditions, and how can we treat these conditions? When we have left anterior fascicular block, so we have blockage at the level of the anterior fascicle of the left bundle. So here, not all the left bundle is affected. We just have the left anterior fascicle that is affected. And in that case, on the ECG, we will have a left axis deviation. So I will show you about the axis in the next slide, but left axis deviation is when you have a positive QRS in 1, and you have a negative QRS in AVF, and a negative QRS in lead 2. In that case, we can say that we have a left axis deviation. And we will have QR complexes in lead 1 and AVL. I will show you why we have that in the next slide. So here is a small Q wave, and so here is a Q, and here is an R wave. So in 1 and AVL, we see this QR. And in inferior leads, so in 2, 3, and AVF, we can see RS complexes, so the opposite. So we have a small R here and an S wave. So R wave followed by an S wave. So this is left anterior fascicular block. So the diagnosis is made on the electrocardiogram. We have left axis deviation associated with QR complexes in lead 1 and AVL, and associated with RS complexes in 2, 3, and AVF. So the diagnosis is on the ECG, as I said. Here is how we know what is the heart axis. So when we have positive in 1 and positive in AVF, this is a normal heart axis. So we don't see this in left anterior fascicular block. When we have positive in lead 1 and negative in AVF, in that case we have, and negative in lead 2, as we said, in that case it's left axis deviation, and this is what we see in left anterior fascicular block. When we have negative QRS in lead 1 and positive in lead AVF, in that case we have a right axis deviation, and this right axis deviation, we'll see it in the left posterior fascicular block. So left anterior fascicular block, we'll see left axis deviation. Left posterior fascicular block, we'll see right axis deviation. We'll see about left posterior fascicular block later. So here is the left anterior fascicular block. Here is the left anterior fascicle. You can see that it doesn't conduct electrical activity anymore. So all the electrical activity will go through the left posterior fascicle. It will start by going to the septum. Then from there, it will give electrical activity to the left ventricle. So because it goes before the red arrow, you can see here is the it goes to the inferior lead. That's why we see in the inferior lead we can see a small R wave. Then because the vector goes away from these inferior leads, it will be followed by a negative S wave because the vector is going away from the inferior leads. The inferior leads are 3 AVF and 2. So we'll see the RS shape. So the R wave is caused by this red vector that is going towards the waves. Then it will shift toward the lateral wall of the left ventricle to the blue curve. And this will cause the production of an S wave. Here is the same as we said, so we'll not repeat it. RS and QR and left axis deviation. Now we move to the left posterior fascicular block. So the problem is here at the level of the left posterior fascicle. The left anterior fascicle is working properly in that case. So the opposite here, we have a right axis deviation. So we have a negative QRS in lead 1 and a positive QRS in lead AVF. When we have this, we say that we have right axis deviation. And to the opposite of left anterior fascicular block, we have RS and 1 and AVL. So we have RS here, small r, and big S wave. And in inferior leads, we have, so in 3, we have a small Q wave followed by an R wave. So Q, R. When we see this, we can diagnose left posterior fascicular block. So right axis deviation with RS complexes in lead 1 and lead AVL. So 1 and AVL, we have RS complexes. And in inferior leads, we will have QR, so small Q and R wave. In that case, we can diagnose easily left posterior fascicular block. Same thing here. It explains why we have this. It's not very important. You just need to know how to diagnose it based on the electrocardiogram tracing. So now we move to the complete right bundle branch block. We said that in the right bundle we just have one division. Okay, so Ahmed is asking me, is the QRS wide or narrow? In case of left anterior fascicular block or left posterior fascicular block, the QRS here is narrow because when we have a blockage, for example, in the anterior fascicle, the posterior fascicle can still propagate electrical activity. So left ventricle and right ventricle will contract at the same time. So when you have simultaneous contraction of right ventricle and left ventricle, we have a narrow QRS. For example, now we will talk about right bundle or left bundle branch block, complete blockage. In that case, you will have a widening of the QRS complex. So left anterior fascicular block and left posterior fascicular block, you will have a narrow QRS complex, but right bundle branch block or left bundle branch block, you will have a widening of the QRS complex because here the left ventricle and the right ventricle are contracting not simultaneously. So here we'll start by describing the right bundle branch block. So as we said, the QRS duration will be wider. So if you calculate here the QRS duration, it's 1, 2, 3, 4. So it's about 160 milliseconds. So here it's a wide QRS. And we have a pathognomonic pattern, which we call the RS R prime. So it's like an M. When you see this on the ECG, you need to, and with a wide QRS, we need to think of right bundle branch block. And you see this in lead V1. It's very common to see it in lead V1. So R wave, which is a positive deflection of the complex, followed by an S wave, which is the first negative deflection, and followed by a second big positive deflection, which we call R prime, so RS R prime, or M shape. This is with a wide QRS, this is considered right bundle branch block. And what can cause right bundle branch block? So most common causes of right branch block is the diseases affecting the right ventricle, because the right bundle branch block will circulate in the cells of the right ventricle. So any cause like right ventricular hypertrophy, for example, you have thickening of the myocardium, so this will cause compression on the bundle branches. pulmonary embolism. So pulmonary embolism will cause high pulmonary pressure, which will cause RV strain because the right ventricle is just before the pulmonary artery. So any pressure after the right ventricle will cause the RV to become weaker. Ischemic heart disease, we said that loss of blood supply to the bundle branches like the SA node and AV node and the His bundles will cause blockage in the system. Myocarditis, congenital heart disease like atrial septal defect, we'll see examples later on. Cardiomyopathy, and this famous disease that we already discussed, Lenage disease. So I will give you a few examples. So right ventricular hypertrophy. So this is a transthoracic echocardiogram, TTE. You see here the left ventricle and you see the right ventricle. If you look well, you see that the wall of the right ventricle is very thickened. These are the walls of the right ventricle. They are more than 10 millimeter in width, so we call right ventricular hypertrophy. The bundle branches are usually found on this part. So when the wall becomes thicker, there's a risk of compression on the bundle branches. So the risk of right bundle branch block. So RV hypertrophy is common cause. Another cause is pulmonary embolism. So pulmonary embolism is the blockage of the pulmonary artery. So you can see here, here it's a normal pulmonary artery, but you can see here it's if we have like a thrombus, it's a filling defect. So the contrast is not filling that area. So this is a thrombus. So we have a blockage in the level of the pulmonary artery. So blood will accumulate before this, and the pressure here will increase, and the pressure will increase as well in the right ventricle. So this can also impact the conducting system of the heart. Here is a transthoracic echocardiographic view. Also, you can see the left atrium here, the right atrium here. And normally we should not have a communication between the left atrium and the right atrium. But here we can see the intra-atrial septum is, you have a breach inside it. This is called an atrial septal defect. And an atrial septal defect usually can be associated with right bundle branch block on the ECG. So it's a way to diagnose it, in fact. So there is now increasing literature data suggesting that when a patient comes to the ER with chest pain and new onset right bundle branch block, before we just say new onset left bundle branch block, but now the data shows that also new onset right bundle branch block should be concerning for acute myocardial infarction. So we need to think of acute myocardial infarction and activate the cath lab when we see a new right bundle branch block and a typical chest pain. So we need to do a coronary angiography in order to rule out coronary artery disease. You need to do it urgently. Now we move to the left bundle branch block. So left bundle branch block, we said, contains the left anterior fascicle and left posterior fascicle. When these two branches are blocked simultaneously, we'll have something called complete left bundle branch block. So as we said, the QRS duration is above 120 milliseconds. So it's a wide QRS. And here you can see in V1, in right bundle branch block, we saw an SR prime or M shape. Here we see the opposite. We see the W shape, or we call it an S wave. So it's a purely negative S wave in V1. Unlike right bundle branch block, which we saw an SR prime wave, which is a positive wave. So when we see prolongation of the QRS duration, we should always suspect either right bundle branch block or left bundle branch block. So when we have RSR prime in V1, always look at V1. It's the most important lead to diagnose it. Look at V1. If you see RSR prime shape, so it's a right bundle branch block. If you see a pure dominant S wave, like here you see in this picture, or W shape, this is diagnostic of left bundle branch block. So just look at V1 and on the duration of the QRS, if the QRS is narrow or if the QRS is wide. So the diagnosis is simple on the ECG. So causes, like we said, in the right bundle, we have things in common. Here, we can have aortic stenosis because the aortic valve is closer to the left bundle branch. So it can, when it becomes stenotic and calcified, the calcifications can propagate and reach the left bundle branches. So it can cause blockages at that level. Ischemic heart disease as well, loss of blood supply that's giving blood to the bundle branches. Hypertension, because why hypertension can cause bundle branch block? Because hypertension can cause ventricular hypertrophy. So as we said, in the right ventricle or in the left ventricle, the septal hypertrophy will cause compression on the electrical conduction fibers. So we'll have bundle branches blocks. Myocardial infarction, as we said, anterior myocardial infarction, because the left anterior descending gives most blood supply to this area. Hyperkalemia, like any other block, it's present everywhere. And digoxin toxicity, which is a medication used to treat supraventricular arrhythmias. We can give it sometimes in heart failure to decrease symptoms. Same as we said in right bundle branch block. Here, when we see a new onset LBB, left bundle branch block, and chest pain, here it's an absolute indication to activate the cath lab, to send the patient urgently to the catheterization lab and do the coronary angiography to see the arteries. It's an equivalent for ST elevation myocardial infarction. So a new onset bundle branch block and chest pain is equivalent of ST elevation MI, STEMI. So here we should do the coronary angiogram, which we should place the stent. We can sometimes have association between these conditions. So you can see here we have the right bundle branch, which is blocked. So this is blocked. The left bundle branch is not completely blocked. We just have a blockage in the anterior fascicle. So we said anterior fascicle, posterior fascicle. So here we have something we call bifascicular block. So we have a right bundle branch block and a left anterior fascicular block. So the right bundle branch, we know how to diagnose it. We said, so we see an RS R prime shape with a white QRS. And in the left anterior fascicular block, we should see a left axis deviation. So when we see this combination, right bundle branch block with left axis deviation, in that case, we should diagnose a bifascicular block with right bundle branch block and left anterior fascicular block. Sometimes we can have right bundle branch block with left posterior fascicular block. So it's the same, right bundle branch block, white QRS with RS R prime in lead V1 shape, so M shape in lead V1. And the posterior fascicular block will give us a right axis deviation, as we said before. So any right bundle branch block with a right axis deviation is a bifascicular block consisting of right bundle branch block and left posterior fascicular block. So here we have an association. We have two fibers that are blocked. So here for sure it's more dangerous. And here it's if the patient comes with symptoms like syncope or other symptoms of fatigue, or we should consider putting a pacemaker. So here is an example. Can someone tell me here, this is a right bundle branch block or a left bundle branch block? Please write in the comments. Look at lead V1. Okay. So here is lead V1. We always look at lead V1. Yes, Ahmed said it's a right bundle branch block, which is true, because we have widening of the QRS interval. So the QRS here is around 140 milliseconds. So it's a right bundle branch block. And if you look on the axis, we have positive in lead 1, we have negative in lead AVF, and we have predominantly negative lead 2. So it's a left axis deviation. So right bundle branch block with left axis deviation, as we said, is a bifascicular block. So blockage in the right bundle branch block and the left anterior fascicular block of the left bundle. So it's a bifascicular block. So most of the time it's associated with structural heart disease. So 50 to 80% is due to structural heart disease and fibrosis. So in that case, the progression to complete heart block is about 1 to 4% per year. And in that case, if the patient comes with syncope or symptoms, we should put a pacemaker. If the patient is asymptomatic, we can wait because 1 to 4% is not a lot, so we can wait on him and observe him with frequent clinical follow-ups. Usually, I have a question. Usually in right bundle branch block, you have a normal axis usually. Sometimes you can have a right axis deviation, but usually it can have a normal axis. But when you see right bundle branch block plus left axis, you diagnose bifascicular block, or right bundle branch block plus right axis, you diagnose also a bifascicular block with a posterior fascicle that's affected. Left bundle branch block as well can have a normal axis or can have a left axis deviation. So the causes are similar to those of RBB and left anterior fascicular block alone. We can have ischemic heart disease, which is the predominant cause because it's a structural heart disease. So about 80% caused by structural heart disease, myocardial infarction, congenital heart disease. And you can see that hyperkalemia is found everywhere. So it can cause all types of heart blocks. Now moving to the last condition, which is a trifascicular block. So here it's the absolute most dangerous condition because here we have blockage everywhere. So we have a complete heart block, so third degree heart block, which is the higher degree AV block that we discussed, with right bundle branch block and with left anterior fascicular block or left posterior fascicular block. So here everything is blocked. There's just only one fascicle that is not blocked, either the left anterior fascicle or the left posterior fascicle. So everything is blocked except one of these two. So it's a very, very dangerous condition associated with mortality and death. So here for sure, we should not wait on placing the pacemaker in that case. The causes are the same as the causes of previous diseases. Will not repeat. It's the same, absolutely the same. And here is an example. So if we look closely, we can see P waves everywhere, not related to QRS complexes. So when we see this, so all of these are P waves, unrelated to the next QRS. So this is diagnostic of complete heart block. So here we diagnosed complete heart block. But if we look closely to the lead V1, you can see this shape. So we have RS, R prime. We have the M shape. Okay, so we have this M shape, and the QRS is wide. So the QRS here is above 120 milliseconds. So here you have a right bundle branch block. So now we have complete heart block with right bundle branch block. And if you look closely to the axis, so anytime we see a right bundle branch block, we need to see the axis. So we have positive in 1, we have negative in AVF, and we have negative in 2. So here it's a left axis deviation associated with a right bundle branch block. So here we have left anterior fascicular block as well. So if you look here, third degree AV block plus right bundle branch block plus left anterior fascicular block. In that case, only the left posterior fascicle is working. So in that case, we call that a trifascicular block, which is a very dangerous condition with high mortality rate. Usually this is caused by ischemia or myocardial infarction, and we need to send the patient to the cath lab, and we need to put a pacemaker as well, because usually it's not reversible, even if we treat the artery that is blocked. So the management depends on the type. So we said that first degree heart block, we don't do anything unless it's a very significant first degree heart block. So if the PR segment is above 300 milliseconds, in that case, we can think of placing a pacemaker if the patient have symptoms. The second degree AV block, we said we have the Mobitz 1 and we have the Mobitz 2. So Mobitz 1, we don't do anything. Same, because most of the time is due to aging or due to vagal stimulation, so in athletes. So in that case, we don't do anything unless the patient presents with typical symptoms not explained by any other pathology. Second degree Mobitz 2 and third degree heart block, here we should put a pacemaker every time. So we should not wait, we should directly send the patient to pacing because this condition can cause sudden cardiac arrest. Bundle branch blocks, so usually nothing, unless the patient becomes symptomatic and have a bifascicular block or a trifascicular block. Usually we put a pacemaker if the patient is symptomatic, especially. And we need as well to check the drug list because most of patients will be on a heart rate lowering drugs like beta blocker, which is prescribed to almost all cardiac patients. So we always need to stop this medication, especially in cases of second degree heart block and above. So we always need to look on this medication. We will end this presentation by looking on this case. So it's we just have 2 slides left. This is a case of a 50-year-old patient. So the patient have a past history of hypertension, and he is on bisoprolol. So bisoprolol is a beta blocker on 5 milligram dose. So it's an intermediate dose. The maximum dose is 10 milligram per day. He presented to the emergency room for true syncope. So he was sitting on a chair and suddenly he lost consciousness completely. And this was his electrocardiogram upon his arrival to the ER. As I said, we always need to look on the long strip lead. So if you look always on all the new machines will give you this long strip lead on the bottom. We can see a lot of things here. Anyone want to comment on what could be the reason of this patient syncope in this case, please? Look, I'll give you hints. Look closely on lead 2. It's not easy to see, but maybe someone can see it. Look well on lead 2 and tell me what is the problem here. Thank you, Fatima and Amna. Thank you. I didn't understand, Ismail, what did you said? Hypertrophic obstructive cardiomyopathy? No, I don't think it's the case here. I don't think it's the case. No, we have another problem that we discussed in our presentation. Yes, exactly. It's Mobitz 2, as Ahmed said, but here it's not right bundle branch block. It's actually left bundle branch block. Yes, true, Mariam, it's left bundle branch block, but I need you to see the Mobitz 2. So if you look on lead 2, you can see P wave followed by QRS followed by T, P, QRST, P, QRST, P, QRST, P, QRST. Then you have a P wave that is not conducting. So there is no QRS here. We should have a QRS here, but no, we don't have it. So when we see this is a Mobitz 2 AV block. So it's an advanced second degree AV block. So in that case, what should we do? What is the next step for this patient? Should we admit him to the hospital, or can we discharge him? What should we do next? Exactly, we should stop the beta blocker, but most of the time we said that Mobitz 2 will not reverse just by stopping the medication, especially when it's associated with syncope. So yes, we need to admit the patient, as you said, and what we have to do next. So we stop the medication for sure. We admit the pacemaker, we admit the patient, and we put a pacemaker, as Ismail said. So exactly, we put he needs pacing, exactly. Okay, and it's a left bundle branch block, not a right bundle branch block, because these are the complexes. The ones that have a right bundle branch morphology, this one is a premature beat. So this, you don't have to look at this, you need to look at the other. We said that when you look at V1 and you see a white QRS, with a negative wave, so it's a left bundle branch block until proving otherwise. So here it's a left bundle branch block. Okay. So the pacemaker, it's easy. We make a scan. We just open the scan on the chest, and then we try to go to the subclavian vein, and we advance the pacemaker leads in order to reach the right atrium. So we need to put a lead in the right atrium, and we need to put a lead in the right ventricle. So now we can have simultaneous contraction of the right atria and the right ventricle. When we have blockage in the AV node of the bundle of His, we always need to put two leads to have this simultaneous contraction between atria and ventricle. And then we put the battery here under the scan, and we close the scan with we suture it, and it will resolve. The scar will resolve in 2 to 3 weeks, and that's it. These are the references. If someone is interested to go deeper in the topic, you can find the references here. And that was it. Thank you for listening, and I hope it was a good presentation and good topics overall for you. And I want to thank everyone, and to thank the organizing committee as well for organizing this webinar as well. So thank you. Ahmad asked me if we can do MRI with pacemaker. So if we have to do MRI when the patient has a pacemaker, for example, if the patient developed a stroke, a brain stroke, and we need to do an MRI with the new pacemakers, yes, you can do it, but you need to modify the settings. So there's a setting you need to modify before sending the patient to the MRI, but most of the new devices are MRI compatible, so there is no problem sending the patient to the MRI if he has a pacemaker. You're welcome, everyone.